got all the bits here. How will I, there, I don't know wrong and wrong. Somebody tell me. Borodar, Croeso, welcome to the May board meeting of Haldar University Health Board. You will see in some of the papers reference to the fact that this is my last board meeting. My term of office as a member of this board comes to an end tomorrow, and I just want to say a thank you to everybody here. I'll probably say it again, but also thank you to our public who've allowed me to hold this position, and hope that I've tried to do my very best for all the services that we provide, and I'm sure that the board will continue to do that. So I will try and be professional and hold it together while we go through the meeting, but I just wanted to say that up front. Can I remind all the authors of the papers that we have all read the papers, so this is for you to highlight any key issues, but to allow plenty of time for any questions and debate. So thank you very much. So I'm now going to move on to apologies, and we have apologies from Lee Davis, and Sean Ayres is here as the Deputy Director of Operational Planning and Commissioning, deputising for Lee. You're welcome, Sean. Thank you for coming. We have two colleagues who are joining the meeting on Zoom. That is Andrew Carruthers, the Director of Operations, and Michael Gray, the Local Authority Social Service Representatives. I think you will start to see people appear on camera. I'd also like to welcome Peter Skitt, who's the County Director for Ceredigion, who is attending the meeting to provide any additional input for item 4.6. We will also have other colleagues joining us for another paper, and I'll introduce them when they arrive. So, are there any declarations of interest for any items on the agenda?
Anne Murphy declaring any interest in trade union.
Thank you.
Yeah, just regarding paper 4.6 on the SAC, any mention of local authority, Ceredigion local authority.
Okay, thank you. Michael.
Yes, I've noticed there's going to be a short mention of the infected blood inquiry, and I was a solicitor. I am the solicitor acting for several hundred victims, mainly Welsh victims, and for Haemophilia Wales as well.
Thank you, Michael. The others? Okay, thank you very much. So we'll move on to the first part of the agenda, which is the minutes from previous meetings. There are two sets of minutes here, so I'll take them in order. First one from the meeting on the 28th of March. Are there any issues anybody wants to raise of correction on the minutes? No? Okay, thank you. And then we have minutes from the extraordinary meeting held on the 10th of April to discuss the EMERTs. Any corrections on those minutes? No? Thank you very much. And then we have the minutes from the meeting of the corporate trustees held on the 28th of March. Are there any corrections for those minutes? No? Thank you very much. So thank you, Claire. We'll declare those as correct records of those meetings. So I'll now move on to the table of actions. They are there in front of you, but you will see there's some areas where we need to just have updates on progress. So I will turn to the people identified to come in and give us an update of that. So the first one is the annual plan. Does anybody have any particular questions on the in progress update? No? Okay, thank you. So I'll move over on to anything on page 2. Anyone wants to raise? Page 3. there's an item there which is in progress. Are there any questions around that? No? Thank you. And then we move on down the same page to Tumble Crosshand Surgery. Any questions about that?
Chair, can I just raise just a point, just to thank everybody actually for the work that they have done that has settled down very well. We've had to do some work on the building as we advised in the Crosshands Health Centre. So thank you to patients for their patience really whilst we've undertaken that. But I'm pleased to say that that transition has gone well.
Good. Thank you very much. Thank you, Jill. And again, thank you to all members of the team who've made that transfer a success. And then we move on to page 4. There's an item there for update. Are there any questions on it's item 2464?
If I may, please, Chair.
Yes.
It's not.
Can you?
Thank you very much. It's not entirely clear to me what is holding this up from the note here. It seems there's difficulties in organising meetings, but I'm not quite sure what is being done about it. In progress implies something happening, but I'd be grateful for a fuller explanation.
Okay. Andrew, could I bring you in to answer that, please? We seem to have a few problems connecting with our Director of Operations. Andrew, can you hear us at all? Okay, apologies for that. I don't know if there's anyone else can help with that query. If not, we'll perhaps come back to it when we have the connection. Okay, thank you. Right, so if there are no more queries on that item, you will also see attached to the table of actions there is an update on the GIRFT process which has been agreed. Has anybody got any queries about that? No? Okay, thank you very much. So if we can move on to the next item, which is my report, while we see if we can connect to Director of Operations. So my report is there, and obviously you can all read that. Oh, Andrew, are you able to hear me?
Assuming not.
We're assuming.
Joined, yeah.
Okay. I'm assuming that Andrew, although we can see him, can't actually hear the meeting. So perhaps we could
We can try,
we
Chair.
can try and do that. Okay. Andrew, are you able to hear me?
I can now.
Oh, great. Thank you. We had a question on item on the table of actions. Eleanor, could I ask you to just repeat that, please?
Thank you very much. I was asking a question about the in progress. It seems that there's a blockage in getting meetings organised, but I'm not clear as to who and by who. And could you unpack that a little bit more to say exactly what is happening?
I ask, sorry, Helena, can I just ask which action that is?
2464.
It's on the bottom of page 4.
Okay, while I'm just going to, I should say that I can't see the room or see anyone, so I don't know whether that's affecting anybody else that's tuning in to watch today.
No, I know, sorry, Chair, to interrupt. I know I've just checked with the team and the live stream is working, so I think it's just for those that are zooming into the meeting. We've got a problem at the moment, Chair.
Thank you. So are you able to address that question?
Yeah, I would. I'm just finding it. So the bottom of page 4, I can see everything now as well. So, well, the meeting there that refers to is the Children Young People's regional board that's being established under the regional partnership board, which I believe Ardiana and Michael Gray are jointly chairing.
Yeah.
And I'm in the process of identifying dates. There are dates in the diary held, I believe, but maybe Ardiana or Michael, if he's there, would want to give an update.
Ardiana, could
Yeah.
you do that?
Yes, happy to provide. If Michael can hear us, if you want to add anything, please do. So we've scheduled a couple of meetings. There's been clearly a hiatus of many months on the Regional Partnership Board, Children and Young People. Michael and I have taken to co-chair that group, and we've scheduled the first 2 meetings, which is one in July and one in early September. And we're reviewing the terms of reference, and we've taken a few actions, which the constituted board will receive some actions fairly soon, practically imminently.
Thank you.
Okay. Thank you very much. Thank you. So if I can take us back to the Chair's report, and I've already mentioned that this is my last meeting. You'll see in the first page that it does reference thanks to the current interim chief exec and the previous chief exec, but I would actually also like to thank all the members of the board. So our executive team, those who are here and those who were in post when I joined in 2016, which feels quite a long time ago. There's been a lot happen during that time, and also 2 independent members, the current and past independent members, and also to the previous 2 permanent chairs, Bernadine Rees and Maria Battle, who've made both my time as a vice chair and actually interim chair all the easier for the work that they've done. So thank you very much. And obviously also welcome to Dr. Neil Wooding, who will be taking over as chair from Saturday, although I think he's not coming into the office until Monday, which is fine. I know Neil will be an absolute brilliant chair. I've had the pleasure of working with Neil in the past, and I do wish him every success in the future, just as I do for the whole health board. And I am a resident of Haldar, so I will be keeping a watchful eye on how things develop and be in touch if I do still hear comments from the public to let you know. But thank you very much. Just a few other things on the report to highlight. On page 2, you'll see there are 2, there's chair's action, which we will need to approve when we come to the recommendations. On page 3, I would like to highlight and say a huge thank you to Christine Bowen, who actually completed almost 60 years NHS service. Wasn't continuous, she did have some breaks, but it's just remarkable, absolutely remarkable, and just demonstrates the dedication of our staff to have worked so long in the health board, and you'll see the details there. You'll also see that there's been some amazing achievement awards, the Lifetime Achievement Award, which was awarded to Barbara Morgan, and then also the Long Service Awards, which were have been completed in the last period. And it will be reported next time, but there was a Chair's Commendation Awards event yesterday, and again, the stories of the those award winners and the things they've done and gone. The phrase above and beyond was repeated so many times in those commendations. It's really very heartening, and we had over 50 staff who were there, which was a brilliant turnout, and I do hope that you'll, if you can attend those events if they continue, then they are really wonderful. Finally, I'm delighted to announce that the Minister, or now the Cabinet Secretary, has agreed to reappoint Ewan Thomas as an independent member on the board for a further period of 4 years. So I'll take any questions before we move to the recommendations. Eleanor.
It's not a question, but on behalf of all the independent members, we'd like to say an enormous thank you for the work and dedication you've done at Hywel, for the individual support you've given to each of us, and we wish you all the very best in your new job, and we will miss you very much.
Oh, thank you very much. Okay, that's enough. Thank you, it's very kind.
I'll keep the rest for later then.
Oh, yes. Thank Thank you very much. Right, if there's no more questions, if I can refer to the recommendations that are there, and in particular to ratify the actions undertaken by myself in appendices 1 to 3. Content to do that? Right, thank you very much. So I'm now going to hand over to Phil, Chief Exec report.
Thank you, Chair. Look, it's a new format, this report, a lot more detail than previously. That's because we have subsumed the previous operational report from the Director of Operations into the Chief Exec report, and it includes the updates from the sort of the committees that sit beneath the executive team. So hopefully it gives a clearer indication of the activities of the executive team and the groups that report into the executive team. So I appreciate members will have read the report, and maybe I should move this here. Appreciate that members will have read the reports, but of course I didn't want to, Chair Judith, gloss over too quickly the first part of it. You have dedicated over 8 years of your life to this organisation, and you know it's a challenging job, and we have really appreciated your commitment and your determination for the population and the over 13,000 staff that we have, and you've really applied yourself and gone way above and beyond what would be normally expected. So thank you for that. Also, thank you personally for your wisdom and support as a new interim Chief Exec. Having you by my side has been fantastic. And I suppose we will miss your direct and incisive questions as you leave tomorrow. But we really do wish you well and all the best in HEIW. We'll be looking for your support, sending those trainees towards us, helping fill our future workforce. And I know, you know, with that job, it will bring some extra time for your garden and for Chris at home. So look. And as I suspected, you will be watching us very carefully, as you are one of our residents, like many of us. So thank you again.
Thank you.
And I will stop there for the moment. But also, you know, we will be welcoming Neil on Saturday, but as you say, we'll meet him on Monday, and we will make sure Neil has a warm welcome. And you can see from the report the kind of experience that we are getting in Neil as a chair, and I know we're all really looking forward to working with Neil in the future for our population, our staff. So just a few things to highlight from the report. You can see there's a lot of information in there. I'm not going to go through all of it, but to highlight the joint committee arrangements, you can see that we've had communication from Welsh Government, so that work is moving at pace. We are in discussion with Welsh Government around the precise arrangements, and I've already had conversations between myself, Neil as the incoming chair, and Richard Evans and Jan Williams in Swansea Bay. So that, I think, will be an important committee for us, looking at services across the region where it makes sense to do so. The other area I wanted to highlight was the infected blood inquiry item. Clearly that's affected so many people across the UK. And it has been long awaited, and I wanted to, on behalf of the NHS, I've worked in the NHS a long time, offer an apology to all those affected. And you can see that we're putting in arrangements for testing of those who are newly concerned, understandably, from the findings of the report. You'll also see that there are 2 recommendations where we'll need to approve when we come to the recommendations around the critical care standard operating procedure and the collaboration agreement. You can see that the collaboration agreement towards the end of the report for Flying Start Healthy Child Wales programme is a retrospective approval. We also anticipate that we will be asked to formally extend that through this for the next year, and expect to receive details on that from Pembrokeshire County Council shortly. And I think that's the last thing I wanted to suggest is that we have an update from Jill Patterson on the St David's practice, because the information in the report is probably now out of date just because of the timing for submission of the papers. There's been more activity, and I felt that we should have an update on the latest position.
Right. Could we come to that first before we move to questions?
Yes, thank you, Chair. And I think it's really important that the board understand the consideration we've given to the process we're following in view of the announcement of the general election. It's very clear from guidance that we shouldn't be making fresh decisions, launching new consultations. However, as the board are aware, we are in a 6-month time scale, and guidance, the up-to-date guidance from Welsh Government hasn't been issued yet. We have looked at previous guidance, and it is clear that where there are systems or services in place that to cease would be detrimental to the quality or safety of services that we provide to patients, then they should continue. So we will be continuing with the face-to-face engagement that we have on the 18th of June. That is part of a wider series of opportunities for patients and local stakeholders to engage with us. Those are available online in terms of the way in which people can contact us. So we look forward to talking to patients at that time. We also know that we won't be making a decision until the end of July at our next board meeting, and therefore, again, it's within the guidance that has been issued. So that is in train. It's a really important event for us to be able to engage with our public, and we look forward to individuals turning up on the 18th of June. Just wanted to confirm that that would be continuing in line with the guidance that's been issued.
Thank you very much, Jill. Okay, I'll now open it for questions on Phil's paper. Dareth and Michael.
Diolch yn fawr, Cadeirydd. I've got 2 questions, if I may, Phil, and it's in regards to the joint committee. And can you explain to us and to the public what that actually means for our residents of Hywel Dda? And have we got the assurances that our residents of Hywel Dda will not be treated unequally, or there could be some issues that residents could not have equity of services? So that's one question. And the other question is about Bronglais General Hospital. And I noticed, I can't remember if it's page 4 of your report, in regards to some works on the roof in Myrig ward and another ward. What impact has that got on our patients and our staff, and what are the timescales for it, please?
Okay, yes.
Thank you, Delith. So I'll take the first question on the joint committee, and I may hand over to Andrew Carruthers for the Bronglais question, just to give Andrew thinking time. So on the joint committee, so we've had partnership arrangements in place with Swansea Bay University Health Board for some time now, both through the ARCH arrangement, which is also involves Swansea University, but also bilaterally between our health boards. And there are flows of patients both ways, actually. We do provide a lot of care for people from the Swansea Bay area, particularly at Prince Philip. But also we rely on Swansea Bay University Health Board for quite a lot of specialist services. So we already have those arrangements in place that you'd expect to have. I think what the joint committee does is it really formalises those arrangements, and it raises the stakes significantly, and also means that there will be some Welsh Government oversight of those arrangements. I think the formality will help with the second question that you described, which is concerns about detriment and inequality. And that will always be a worry for populations that are further away from a specialist centre. And it's something we're really mindful of. And the more formality there is in considering services across a region, I think the better for us, because it will mean that those sort of issues will be at the forefront, certainly of myself and the new chair when we're in the joint committee, but also in all those supporting arrangements which our executives and managers and clinical leads will sit in. So we will be equal partners with Swansea Bay. Want to reassure our public in that sense, and we will be certainly making sure that there is no services aren't set up in some way to enhance inequality. So maybe it's worth handing over to Andrew Carruthers at that point on the Bronglice issue.
You Phil. So in relation to Bronglice, we've got some repair work we need to do to the roof above Myreg and Harrod wards. That does mean that we lose some further bed capacity over the course of the period of that work. It's likely that we're working to, so Anne Harrod's already empty because we're doing work there around other capital works that are ongoing that we're undertaking. So we will, there's no additional impact from the work happening in Anne Harrod, but for Myreg it will mean we lose another 14 beds on the site. We're in conversation with the local authority around accelerating a discussion we were having for some step down capacity in Havana Wine, which is a building that they own, and there was a model we were looking to develop as part of our enhancing community service provision. So we're looking at how quickly we can accelerate that work, but there's some work needed in that building just because it's not necessarily fit for there's carpet on the floor and things like that would need to replace the flooring would need doing. So there's a bit of work to do there. The length of work that we believe, or length of time that this will take, will be to around about the end of July before we anticipate Myreg and Anne Harrod. The roof work will be completed and Myreg back in use.
Okay. Sorry, do you want to come back?
Yeah, can I come back on that, Andrew, in regards to Harrod ward, because that is the paediatric ward, if I'm right. How much communication is there with GPs or with our staff in regards to paediatric intake into Bronglice Hospital?
I'm not aware there are any issues, Delith. If there are some specific issues you are aware of and want to flag those to me, then I'm happy to go away and look into them, but I've not been made aware that there's a specific problem with that. That's the work on Anne Harrod is part of a programme, as I say, programme set of works that were planned for the site.
Okay, perhaps we could come back to that outside of an update for you outside of the meeting. Wella, do you want to come on this before I bring other people in?
I was just going to highlight that we have communicated to the patients and the staff who are impacted directly with the move from Myreg ward, and we'll continue to provide reassurance, but it's currently targeted towards Myreg ward.
Okay, thank you very much. Thank you. Michael.
Thank you. I'd like to say very much welcome the comments by the Interim Chief Executive in respect to the infected blood inquiry and the apology. The question is I would put this question to all health boards in Wales, is what are we taking and how are we learning and how are we going to roll that out from what the inquiry says? Now, I appreciate the report was only published on last Monday. It's 7 volumes. I haven't quite got through all the volumes yet, but I would urge everybody to look at volume 1 and read the bit about where Sir Brian Langstaff, the chair of the inquiry, who himself was a leading clinical negligence silk in his day, he talks about candour, culture and risk in the health setting. He also talks about it in the civil service setting, actually, which is interesting. But he talks about it in the health setting. And I have to say, his description and his analysis of risk in health settings, I think, is a really well-written easy to understand, for me anyway, analysis of that. And I think it's something which, I would like to see us trying to roll that out, look at it, learn from it, and try and... I appreciate this was many years ago, it's national, but I think it would serve all health boards in Wales to read, particularly Volume 1, and to actually respond to it, work on it, do something with it. So is that something we would intend to do in Hywel Dda?
Yeah, I would just... Sorry, Phil, you may want to come in, but if I could just say, I think we should take that, maybe, that section through to our quality committee to see, because we obviously have our duty of candour, which is, very early days of that coming in, to see what we can learn. There will, I'm sure, be a response formally to all those recommendations. I know that is what was required of the government to respond to the report, but I think we should look at that internally, and if I can ask Anna if that can come through to the quality committee and work with Sharon in terms of timescale for that. So thank you very much for highlighting it. Do you want to say any more, Phil?
Yeah, only to say that thank you for that, because it is a long report, so it's good to have some direction to where the key learning might be. And there will be some national work on this, of course, but clearly some of the learning will be really vivid and intense from it because of the scale of the challenge. So I'm grateful that was what I was going to suggest. Actually, we also take it through locally through our quality arrangements.
Okay. Yeah. Thank you very much. Thank you for the question. Chantal.
Yes, I just wanted to come back to the joint committee, and just wondering whether the terms of reference are going to be imposed by the Welsh Government, or whether that's going to be a joint agreement between the relevant parties.
Thank you, Chantal. So actually that does give me a chance to say one other thing I wanted to say about the joint committee as well. So in terms of the terms of reference, we're in discussion with Welsh Government at the moment about the terms of reference, because clearly both organisations, I know both incoming chairs, want to take ownership of this and want it to work for our populations, because we do see real benefit potentially for our populations from having the joint committee arrangements in a more formal way. So I'm sure that we want to take the advice and support from Welsh Government, but we will want to own this and want to make sure our thoughts and our ideas are imprinted within those terms of reference. The other point I was going to make relates to that, really, that the advantages we see are that there are some services that are best considered across a larger population. And between us, we have nearly 800,000 people within both of our health board boundaries. So it's really important that we consider those populations, not just in those specialist services particularly, not in smaller populations. Otherwise, you just don't get the best quality of care. And that doesn't mean that all services, therefore, have to be provided within the Swansea Bay University Health Board boundary. Some of them will be able to be provided within Hywel Dda, because Morriston is only so big, you can't fit everything in there. So it will mean that we will be looking to get some services in our footprint, which I think will be good news for our population. The other thing to mention, of course, is we do have our Mid-Wales arrangements with Betsy Cadwaladr and Powys. So just to say that we haven't forgotten, actually, that we're involved in two collaborations there, really, with different health boards for different populations that rely on us.
Thank you, Phil. Maynard.
Thank you, Chair. I'd had questions that have already been answered on the joint committee, but two things. The measles vaccine update, the report notes that the uptake varies between 30 and 70% across Wales, and I was just wondering what our uptake is. I know we've got the immunisation strategy coming up later on the agenda, which will address how we're taking that forward. But the second question relates to Cross Hands full business case. Last sentence that is, it's noted the business case is not progressing at this time. Just wondering, how long is that business case going to be put on hold, and how long it will be before we can actually take forward that? Because I know that that's being looked at for at least 4 years or more.
Thank you, Maynard. Can I ask Guardiana just to give the immunisation rates for measles?
Thank you, Maynard. So, yes, we have the immunisation strategic plan coming up for after lunch on the board for discussion and approval to be submitted to Welsh Government. And in that, we'll see some of the high-level strategic actions that we will be taking, which we have already started autumn time, to improve the inequalities in uptake, which essentially means to increase the uptake in our areas which we know where the uptake, particularly for MMR1, falls below 90%. We do have several practices, particularly in our South Ceredigion and North Pembrokeshire, which have MMR1, which is the first dose of MMR for children aged 12 months, that fall below 90%, which is the required minimum uptake to maintain a level of immunity that we should not be at high risk for outbreaks of measles, and with cases of measles increasing almost daily across Wales, that is our top priority. Thank you.
Thank you very much. Do you want to take the cross hands?
Yeah, happy to. So the Cross Hands full business case item is at the bottom of page 5. Of course, that's a really important development for that area, Cross Hands and Tumble, and has been much awaited for some time now. The issue essentially is that the costs have increased because of inflation. From what we had anticipated originally. So we're in negotiation with Welsh Government. We're looking at the business case to see how we can mitigate that at the moment. So that is what the issue is. So it's not that the business case has been in any way shelved. It's more the fact that we're looking to mitigate the costs of inflation.
Okay, thank you. If there are no more questions, I just need to just make one correction. I think the public event, Jill, for St David's is the 14th of June. I've been told not the 18th, so I just need to correct that. No, it's fine, so that everybody is aware who may want to attend. So I've now got, if there's no more questions, I'll move us to recommendations. You've got 2 there, first 2 to endorse and note, and then we need to approve the critical care standard operating procedure, Appendix C. You're content to do that? Yes, thank you. And also approve the collaboration agreement for Flying Start Healthy Child Wales programme. Content to do that? Okay, thank you. Thank you very much, Phil. So I'll move us on to item 2.7, which is the report from the Audit Risk and Assurance Committee. Rodri.
Thank you, Chair. And firstly, can I also thank you for all your work, and also as Chair of ARAC for all those to-the-point, concise questions that we have when people come in front of us and sit on that blue chair. But thank you ever so much for all your hard work over the years. Right, okay then, so we'll just look at the first of the 2 papers, the 16th of April. There was nothing there to alert the board, but there were quite a few points there to be advised. And I think I'll just go through them very quickly. So the contract and procurement processes, the use of G-Cloud framework has been stopped unless approved by the Financial Control Group, and robust measures were now in place to ensure appropriate procurement processes are followed. And also to advise board that a further update report outlining the lessons learnt and providing assurances on the future training provision for key officers and relevant staff would be provided to the committee at a future meeting. So, internal audit review of discharge management, you can see that was a limited assurance. The committee were very concerned regarding this matter and have asked for an update on progress to be presented to the August meeting to gain assurance that challenges and issues identified in the report are being addressed. Internal audit follow-up review of consultant job planning, again, limited assurance. Committee have asked for an update on progress to be presented to the August meeting. And also the Mental Health Directorate were highlighted as a service of concern in the audit tracker report. And this is the second consecutive time they have been identified with a concerning trend of overdue recommendations. And it is fourth time over the past year the Directorate has been highlighted to ARAC with a concerning trend. Therefore, you can see it's going to be escalated, and I take it that you've read the rest of it. Regarding assurance, you can see what these are all to note then, the TI escalation status report. Audit Wales, I think this is just to, I need to just say that that the assurance to the committee on their work plan, and assure the committee that the report on their review of operational governance arrangements would be presented at the next meeting. The draft annual accounts are due to be submitted to Audit Wales on the 3rd of May, and the audit deadline is the 15th of July. A draft report will be submitted to ARAC in advance of this deadline. And the rest is to note. I just want to highlight, perhaps with counter fraud, Ben and his excellent small team are very good in their work, and as always are excellent in doing the work that is so important for any health board. Therefore, I do those. I'll just move on then to the 9th of May, and we'll just go through recommendations at the end. So 9th of May, you can see there's one that is to alert the board of, and I will go through this. So the internal audit review of the standards of cleanliness provide limited assurance on the arrangements for ensuring compliance with the national standards for cleaning in NHS Wales, and request the board to support the proposal that the Quality, Safety and Experience Committee oversee this matter. The review focused on 2 acute sites, namely Withybush and Glangwili. The committee were very concerned that these issues had not been identified, and you can see from the text the findings in the report, and they hadn't been identified, appropriate action taken or escalated prior to the internal audit being undertaken, and took assurance from the intention to have an internal governance review of cleaning standards to understand why this has happened and to ensure it does not occur again. Internal audit have been asked to undertake a follow-up review of the recommendations and undertake a review of cleaning standards at Bronglais and Prince Philip Hospital during 24-25. Therefore, and then on to the advise. So the Glangwili General Hospital fire precaution phase, I think we need to note that the rating was primarily, the limited assurance rating was primarily attributed to the financial risk of the unfunded forecast position of the project, and the overspend of 4 to 5 million. However, since the report has been issued, Welsh Government has confirmed additional funding of 4.5 million, which will be available immediately, with a further 2.7 million available to be held by Welsh Government, subject to scrutiny by NHS Wales Shared Services. I think the other point which is important, the draft head of internal audit opinion and annual report provides a limited assurance overall opinion on the adequacy of effectiveness of the Health Board's framework of governance, risk management and control. This was based primarily on the number of limited assurance reports issued in 23-24, the significance of the risks associated with these, and the insufficient progress to address previously identified weaknesses. I do think, and we've had this discussion in ARAC, that we are looking at and we know any issues that are of concern. We ask internal audit to look at these, and I think that is the best and most transparent way of doing it. And for some reason, well, and we've come out as a limited assurance, but if we can't, we need to ensure that what we've got in place and the areas we think are of weakness, the only way to improve those is to have internal audit there. So therefore, really, was probably in a way, by doing that, that's why we've come out as a limited assurance. But then after saying that, we know we've got a clear plan in place to improve and to move forward. And then just to note then the assured part of the paper that I've got in front of us, and I'm not going to go through all that. And then just the review of risks. The audit committee will keep the board updated on any development regarding items flagged as to alert and advise. And the only recommendation is that to note and approve the revised standing orders, which are attached in 2.8.
you. Thank you very much, Audrey. Are there any questions? Yes, Anna.
Just to assure the board that in relation to the cleanliness standards, we have indeed taken that as read, that the board would wish to support, that the QSEC takes a look at that. It's on our agenda for a couple of weeks' time, and as well as looking at the issues themselves, I think what I'll also want to do with exec colleagues is to consider how we haven't clocked this sooner. Because those sort of governance weaknesses apply at every level of governance in the organisation, including our committee. So I will want to consider what lessons we can take from that experience and ensure that it doesn't happen again.
Thank you, Anna.
Okay, any other questions? I would probably just like to say one thing on that, because I think many of us, when we go round, we do note how hard our cleaning staff are actually working. And so I think whilst there's a lot of detail in that audit report, what it isn't doing is flagging that our staff are not working very hard to do the best they can. I think it's important to state that, and that the matters of concern are outside of that, the very hard-working and difficult job that they do every day. So I just wanted to state that. Yes.
Yeah, just to say, so I absolutely endorse that and was also concerned about that particular report. Also wanted to say, of course, there are quite a number of limited assurance audit reports. We need to recognise that as a board. And that's something probably new for us. I know we are directing our internal audit colleagues to some of the areas that we want to learn from most. And one of the reactions could be to stop doing that. We really mustn't do that. We really must continue to use internal audit as a really key assurance mechanism for us. And we do need to try and make some progress, particularly on the ones that are coming back more than once with a limited assurance on them. So I just wanted to highlight that is an area of focus for the executive team.
Thank you very much. Okay, so are we happy to note the report and approve the revised standing orders? Yes? Okay, thank you very much. So we'll move on to the report from the Quality, Safety and Experience Committee. Anna.
Are we skipping revised model standards?
I think Judith.
Oh, sorry, I did say approved. Did you have any questions? Sorry.
No, sorry, I must have missed that. I was
Yeah,
concentrating on my next item.
I did say approved.
Apologies.
I did say
Apologies,
that, didn't I?
Judith, my
It will
my
be
oversight.
recorded, so you can check it later. Well, I think I did say approve them.
I was too busy thinking, what am I going to say about my item? But I will start by saying, as colleagues going before me have done, our thanks, Judith, on behalf of QSEC, current and past members, for your enormous contribution as a member of that committee through, I think, almost all of your tenure, your support to me as chair of that committee, and your personal support to me as an independent member. And I'm hoping that in your new role in HIW, we will be able to continue to do some future work together around gender equality, about which we both feel very passionately. So I hope it's not the end; it's a new beginning. But moving on to the QSEC report then. The report stands with one minor adjustment that I'll mention towards the end. I would like to draw the board's attention to the appendix, which covers a really helpful overview of our participation as a health board in the All Wales Safe Care Collaborative. It's a really thorough report that we took at the committee. It includes some really uplifting stories about the way in which quality improvement has been applied in our organisation through this collaborative. I think it also highlights the really good foundations that we have had through our EQUIP programme to contribute to that national picture, and indeed I think the National Collaborative has benefited from the learning that we have generated over many years involved in the EQUIP programme. So it shows yet again the wisdom involved in supporting that EQUIP programme when it was really quite innovative several years ago. And it's also great to see there the staff stories that are shared, and once again shows the power of being able to offer these opportunities for staff to really make a difference in the work that they feel so passionately about. So that was a really great item to be able to consider at the committee. On a less positive note, while I don't have any issues to alert the board to, we have a number of issues that are on the advice under the sort of advise section, which have the potential to escalate, but at this point in time we are content that action is in place. I do just want to highlight the risk item, which refers to the aseptic unit facilities at Withybush Hospital, and board members will be aware that this is a really critical part of our cancer pathway, treatment pathway. And I raise it here just to highlight that I think the committee was left with some degree of confusion as to the extent of the risk that was that we tried to work through in the committee, but it is back on the agenda for next time to be able to sort of finally bottom that out. And it had previously gone through the executive risk group, so that sort of confusion as to the level of rating was somewhat of a surprise for the committee. So we're working through that, but I think there may be a bit of just a glitch in process there in terms of the information coming into the committee. And then, so just finally then, the minor adjustment to the report is we have jumped the gun in asking the board to approve the QSEC annual report when in fact it's not coming until July. So the recommendation today is to note the report. Thank you very much. Happy to take questions.
Thank you. Jill, I think you want to come in.
Yes,
about
I was just
aseptic.
hoping to offer some clarity on the issues here, and it may be the timing of the board report because it does include the update. So in the committee, there was, as the chair of the committee has advised, some consideration as to whether the risk, because of mitigations that had been put in place, were still at the level of a risk score of 20. So I was asked to go away, work with the team to do that. So we went through the correct process of having that discussion. The team then met with the corporate governance team to review that risk, and as a consequence, the risk was reduced from 20 to 15. But clearly that happened, and the board report has been written with the updated position. So it is correct, and it is also correct in the later corporate risk update, where it again sets out the detail of the work that was taken place to reduce that risk from 20 to 15. So I hope that clarifies. I think it's just the timing of this board report that's perhaps...
Thank you. Joe, do you want to say something?
Yeah, I just wanted to say really, it was quite an awkward moment for the committee. So what we've done is, as you'll see on the corporate risk report, that particular risk is going to be reviewed, go back through the exec risk group before it goes back to quality and safety, because it was a really difficult position for the committee to have a 25 risk and then to be a verbal update to be a 15. So that's why we've, from a governance process, to close that loop, we're now taking it back through the June meeting, but it does need a full review in exec risk group first, Chair. So we're picking that up with Jill and T.
Okay, thank you very much. Thank you. So, any questions for Anna on that report? No? Okay, thank you very much. So, if we move on to a section of papers related to the annual plan. So, first of all, we'll deal with the closure report for the annual plan for 23-24. I'm going to ask Phil to take these items.
Yep, thank you, Chair. So members will have read the papers. It's a closure report on last year's annual plan, and so it's a look back. The one table I would particularly draw attention to is on page 3 of the SBAR, which links this year's planning objectives with last year's planning objectives. So we've got the read across from last year to this year. But happy to take any questions, and I'm sure other execs on particular planning objectives would be happy to answer questions.
Okay, thank you. Any questions of this closure report? I've got Maynard, then Anna.
Thank you. Thank you, Chair. On page 283 of the pack is the closure report for plant care and cancer recovery, and it notes that the number of patients on the cancer pathway over the 62-day standard has improved by over 25%. I would just like some clarification over what period that improvement has taken place and what are the actual numbers involved. It doesn't say whether we're actually achieving the target that has been set for us.
Do you want me to bring Andrew in on that question? Did you hear that okay?
Yeah, I did, yeah. I think it's important to note that we've treated 130 patients more this last 12 months on the single cancer pathway than we've treated previously. The backlog has reduced, albeit marginally, over the course of the 12 months, but it's reduced quite significantly from the high of the backlog we had, which was something like 550 to 600 patients around 18 months ago, and it's now just over 400. So I think there's been improvement over a sort of 18-month period of time over the course of the last year in terms of the number of people. So the backlog being the number of people that are still waiting over 62 days, it's more of a marginal improvement of about 22 over the course of the 12 months. Clearly, from my perspective and our perspective, that's not good enough or acceptable. It's an area of performance that's been identified as key in our targeted intervention escalation. As you look in the performance report, you'll see that for March, we have managed to get to 60%, which is encouraging because we hadn't previously got there for about 2 or 3 years, I think. And I'm expecting that as we go through this year, although I think there might be a blip or two along the way, I'm expecting our performance to be much more resilient and stronger in the high 50s and 60s, particularly as the year unfolds. I think we'll have certainly a blip in May, which is linked still to some of the impact of strike action in February, March time.
Okay, thank you. Anna.
Thanks, Chair. My question is more about looking at this in the round. So if we look on page 2 of the report and the sort of scores on the board in terms of the 23 planning objectives, in numbers terms, we can see that on the whole, I think this is presented in such a way that tells us on the whole we did okay. So 16 were either completed or on track out of those 23. And yet in the same year, we've been moved into targeted intervention across the whole of the organisation. So there's something for me that feels tricky about that. And when I look further at the data, of course, what we can see is that within those 4 that were behind, one of them is the money. Which led me to think, well, if there's a sort of a trump card within this, does that alter the way we think about inclusion of that within the definition of a planning objective? Is a statutory duty, i.e. the duty to break even, something that should be a planning objective, or is there a different way of needing to describe that requirement? Just curious about that, really. There's something for me that feels just a bit uncomfortable about that.
Yeah, that's a good point. Phil.
Thank you, Anna. So I suppose, excuse me. So I suppose it was never meant to be a sort of a scorecard of trying to get more planning objectives completed than not. And there is a recognition, I suppose, that some are more supportive and some are more outcome focused. I do think the way we've described them this year will give us more focus on the reasons we went into whole organisational targeted intervention, and they were designed in a way to reflect that. And we've also set up our whole executive working arrangements around that. So I think it will be clearer, hopefully, as we go through the year to board through the Chief Exec report and other reports as to whether we're making progress on those planning objectives. So I think we did have over 70 planning objectives at one point, then we went down to 30 something, now we're down to 10. And I do think that will help us be that much more focused. And we will spot those ones, as you say, which really will define our escalation arrangements.
Thank you.
Okay, you.
Thank you, Chair. Just in terms of the Annex 2, in terms of looking at the closure reports, I think it's often people will kind of zone in on the things we're not doing well. And I would just like to perhaps note of something we are doing well as a health board. And this is something that I only discovered last week. Went to a large kind of third sector event held at the Botanic Gardens. And it was great to see how all our colleagues there in terms of working with communities, in terms of supporting some of the additional things that we do, which perhaps we don't highlight. And I, just scanning through the report last night, think it relates to planning objective 6C with continuous engagement, population health into 7A, local economic and social impact under 8B. And that is our team within Hywel Dda who will support our patients whilst they're with us, they also have the opportunity to learn and actually to get accredited qualifications. And the stories from patients that I found out last week was incredible in terms of the things that we offer as a health board to any of our patients, for regardless of their tenure with us, or for what they're actually going through, that we can support them with accredited learning from their hospital bed. And this team that I met in the Botanic Gardens were incredible, and I don't think perhaps we do enough as a health board to promote the additional services around patient wraparound care. We all know that perhaps it happens, but perhaps I think our public doesn't. I think perhaps there's something that we can do to highlight the amazing work of our teams that actually offer this additional support, which provides not only the support of the physical well-being that we're doing, but also their mental well-being and their kind of general socio-economic well-being, which then they can take back into their communities. So I think it was a great story for us as a health board that perhaps we don't exactly perhaps highlight, but it's around our patients and what we actually do for them, which perhaps we don't perhaps promote enough. So just to note.
Yeah, it's really helpful actually. Maybe I won't be here to present it, but maybe something in the annual report could perhaps highlight some of these additional areas. Chantal.
Yes, I just wondered, thinking about on what Ewan is saying, is I wondered whether, as part and parcel of the report, we could have a statement around the impact of what we've achieved in terms of how that plays out as far as the organisation is concerned. Because I can read, we can see the key achievements, we can see those things that are outstanding. What we're not seeing is what impact, as all of the things that we've done have had actually.
Yeah, okay. Phil.
Yeah, thank you, Ewan and Chantal. I think it is really important we highlight these areas because of course, we will inevitably focus on the things we need to improve on. And I suppose everything you're describing there is about our move to a more social model of health and well-being. And I do think how we harness local talent, how we connect with partners, people within communities, is going to define us. I mean, there's all sorts of great work going on out there, and we do need to continue to make space for that as we go forward. The challenge, as Chantal's putting out, is how you measure impact. Measurement of impact when you do a hip replacement is much easier. The measurement of impact of work with partners, developing local talent, developing community resilience and connectedness, all so much more difficult because it's so multifactorial, but we know it's the right thing. We need to try to demonstrate, bring it to life somehow, even if it doesn't respond well to conventional measurements. So we'll do our best in this annual report, but I suspect that will be work in progress for future reports as well. Thank you.
Okay, thank you. The recommendation is there, which we're asked to take assurance on the progress of the planning objectives for last year. Happy with that? Thank you. Right, and move us on. We have two papers now, 3.2 and 3.3, which I think Phil is going to take together. Before I ask him to do that, can I just thank Sean Ayres for all the work that he's done on the paper and the extra paper, which was produced quite late, but he worked very hard on. So, Sean, thank you. I know you're here to answer any difficult questions that Phil's not able to as he presents this, but I did want to thank you for all the work you've done. So, over to you, Phil.
Yes, thank you, Chair, and thank you, Sean, as well from me for the preparation of all the work on this and the questions you'll be answering. So, yeah, look, I did want to take both papers together. So just to go through a few things, I know members will have read the papers and attachments, but these are important papers. First of all, just to remind us and the public, we did in March endorse an annual plan to allow budgets to be delegated to the organisation to make sure the organisation therefore could operate. However, we did recognise at that time as a board that the financial position was unacceptable. We also recognised, with a projection of a £64 million deficit at the end of this year, that even that position had risk within it. And we agreed that the Q1 actions, part of those would be about de-risking our plan. That was something that we agreed and the executive team was tasked with. We also agreed that in Q2 we would need to describe a route map to our control total, which is 44.8 million, which is that significant gap that we have. And that's with an underlying deficit of 96.4 million. So the challenge financially for us is really significant. Since then, we did receive a letter, as you can see, from the Deputy Chief Executive in Welsh Government for the NHS on the 3rd of May, also describing our financial plan to be unacceptable and not in line with our targeted intervention conditions. Separately, we received another letter on the 7th of May identifying new performance measures, and both of them we need to respond to by the 31st of May, which is tomorrow. We know that what lies behind that financial challenge is a series of other challenges, and we do recognise that we have those challenges as an organisation, and that is why we are in organisational targeted intervention, which we were put into in February this year. And we are, I know as a board and certainly as an exec team as well, committed to really face and tackle those challenges in the coming years. The other thing I would say is that we did recognise back in 2018, when we agreed our strategy at that point, some of the core underlying challenges that result in us having a financial challenge. So the first would be that we have a very hospital-centric system. We have more hospital beds per population than any other health board in Wales, apart from Powys, of course, which doesn't have a sort of a DGH. We've also recognised that we did need to develop significant alternatives in our communities to patients needing to either come to hospital or stay in hospital. We recognised that, and that was a really key part of our strategy. We've made some progress in that, but clearly nowhere near where we would want to. We also knew that we needed to tackle the significant service fragility that we have, with services spread widely across quite a number, 4 hospitals and a wide geography, and the workforce fragility that goes with that, with large numbers of agency, nursing and medical staff. And we've made some progress on that, but clearly nowhere near where we'd want to. And we knew that there were significant enablers, which we set out in our strategy around our estate, infrastructure, IT, digital. So all of those things actually should not be a surprise to us, because this is something we've been working on. It's just the progress has not been significant enough. And of course, we cannot wait for a new hospital to solve those issues for us. We need to make progress in the transition period. So the first paper, just coming back to the first paper, that does outline how we're responding to targeted intervention. It also includes our internal escalation framework and the progress, outlines the progress we're making on that internal escalation framework. The second paper shows areas of our improvement focus, the areas we are intending to work on, which are aligned to our previous strategy, but also will underpin financial improvement in the next few years. We do need to submit to Welsh Government our responses, as I said, to those 2 letters tomorrow. We do have an in-committee discussion to discuss in more detail some of our thinking. We have a board seminar arranged in the next month to discuss this further, the next iteration of that work, and we will be bringing back our progress on that work to public board in July. But happy to take questions.
Okay, so you want to take questions on both?
On both
papers?
reports, and I will be supported by exec colleagues, I'm sure.
Questions? Anna.
Phil, my question's about time, really. So we're looking at an annual plan, so April this year to March next year. We're here at the end of May, so we're actually down from 12 months to 10 months today. By the time the more detailed plan comes back at the end of July, we'll be down to 8 months of the year remaining. And then presuming that there is considerable lead time involved in some of these schemes, we're looking at presumably an incredibly pressured second half of the year to actually see any sort of cash releasing impact of these actions. What is the expectation around compensating for the time that we're losing now? Are we going to be required to make that up in the second half of the year, or is there a recognition that slippage is just part of this process and we won't be able to recover what we are losing while this planning work is going on?
Do you want to say something first?
Maybe if
I'll
I-
bring you in.
Maybe if I just come in for look, I think that's a really key question, and something that as an exec team we're concerned about. We were concerned about in the months leading up to the development of the plan, and we spent considerable effort trying to reorganise ourselves, adjust the way the organisation thinks in a short period of time for the start of the new year. And yeah, it is concerning. You know, we'll get to the financial report in month 1 next. So I think to get to our control total, which of course actually our statutory duty is to break even, but to get to our control total, that's going to need some really significant change in those areas that I've described. I don't think there are other ways to get back to the control total or anywhere near it. So we need at least the part year effect of some of those significant changes within the second half of this year, and we need the full year effect of those changes into next year. But I think, you know, Hugh and colleagues will be able to describe the sort of work that we're doing to get behind those programmes of work now. But clearly, time is a risk for us.
Hugh, you want to add to that?
Yeah, thank you. And it's clearly an area of concern in terms of the pace of delivery. And if I go back to the letter that we've had in, it recognises that the position we have is an unacceptable position. It's not an affordable position for Welsh Government, and that affordability is a very real issue because there is a cash consequence for this, which is of concern. And that difference between the target control total and our planned deficit at this stage represents a cash challenge for us that we haven't got coverage for. So that there is a real burning platform for us to be concerned about. We recognised in approving the plan that this was a novel and contentious action, and wrote to the accountable officer in Welsh Government accordingly. In recognising that £64 million deficit, it's a balance between our ambition for change, which needs to come back to delivering within our means, so delivering within our statutory duty, let alone target control total, and the realism on our delivery trajectory. And that's what we are seeing again being a challenge for us this year. We did say that Q1 of this year needed to be a focus on de-risking. That work is ongoing, and there are some choices that will come out of that de-risking effort before we get on to what recovery looks like. There is a, so month one, when I come on to that, we'll see that there is a slippage already that we're recognising on delivering savings, but there are also non-recurrent underspends in a number of directorates that are partly, not fully, but partly offsetting that. And the conversation I've been having with exec colleagues is around taking that non-recurrent slippage and recognising that and, if you like, banking that against the savings that haven't been delivered as yet, to minimise our cash spend so that we're not pushing all of our issue into the second half and third and fourth quarter of the year. And that's the real kind of de-risking exercise that's going on to practically see how we reduce our cash spend. On top of that, then, we're working on the recurrent plans that we will need to deliver, of which there are a number of very significant choices which we will have to bring back to the board to consider further. Okay,
thank you. Rodri.
Yeah, just if you look at the SBAR, the 3.3, just as you said just now, I think it's an ambition for change, but delivering within our means. And if you look at the response to the Welsh Government letter on the 7th of May, there is one part of the plan care improvement on the annual plan. That part, is that ambitious? There's zero breaches by March 25, and the same as with the orthopaedic waiting list, 0 breaches by March 25. I just want to get an idea of kind of from those two paragraphs on their own, I just want to hear what your thoughts are on that.
So I will bring, and actually Sean wants to come in as well. But just one small thing from me would be that I think I have to recognise the unscheduled care challenge actually is probably our biggest challenge of the three, if we look at planned care, cancer and unscheduled care. But I think Sean wanted to come in, but might want to bring in Andrew as well.
Yeah. Sean, do you want to say something specifically on that? I'll bring Andrew in.
Yes, thank you, Chair. So I guess just to answer the question directly, what we're saying here is that we are confident, based on the actions that we set out in the annual plan, along with the further work that we've undertaken, and through an element of outsourcing, that we can now meet the ophthalmology target for 104 weeks. However, we are being very clear that there is still a risk of 527 breaches in orthopaedics if we cannot at present get the current level of capacity that's required. So what we've put forward there is linked to the regional approach in terms of the monies, that we would need another 4.8 million in order to get to 0 breaches for 104-week waits. So just apologies if that wasn't clear. So that's what we're saying. And at this point, we do not have the 4.8 million.
Okay, thank you. Andrew, I'm going to bring you in. Do you want to say anything specifically in relation to planned care?
And I think to be fair, Sean has summarised that quite well, just in terms of clarifying the position. I think the only other point I would make is obviously we're saying we'll get to 0 in ophthalmology. We're already saying we would get to 0 in everything except ophthalmology and orthopaedics. In our original submission, the work's taken that on a step, and we believe we can deliver ophthalmology now within the original resource envelope we had allocated as a board for planned care from the recovery monies we were allocated. The challenge we've got, though, is that we're saying we could deliver everything except orthopaedics by the end of March. the Welsh Government expectation that they've issued since in the last 2 or 3 weeks is that they would want us to be at that point by December. That's a significant delivery challenge just because of the volume of cases we would need to treat in that time frame. So even within that position, we're still slightly at odds with some of what Welsh Government are setting as their delivery milestones through the course of this year.
Okay, thank you, Andrew. Obviously, we will be having a more detailed discussion about this in the in-committee stage. So if there's no specific questions, I think in terms of trying to summarise, I think what the Chief Exec said is really important to put the context of this, of the strategy, which is going to need a refresh. That's referred to, which you will have seen from the Nuffield report, which I know we'll actually come on to. But this is in the context of what we indicated as a health board we wanted to achieve to improve the services to our local population. So just to reiterate, we will be discussing this further in committee, and then there will be a further paper with more detail coming to the July board after the board has had both a discussion later today but also the seminar later in June. So on that basis, we're asked to note the information in those papers. You're content to do that? Thank you.
Sorry.
Oh, sorry, Michael.
Judith, I've just, Chair, could maybe we say what you've just said in a way,
Okay,
because it's like an
that's
action
fine.
point, and I was going to say
Yeah.
it could be good to have some action points, even though I realise it's all in flow, isn't
Okay.
it? Yeah.
Well, hopefully that was taken down. I'm sure it was, so I won't repeat it. I know Claire will incorporate that into a recommendation, so thank you for that. Thank you. Okay, so I am going to move us on to the next paper, and then we will take a break for coffee. So that's Healthier Mid and West Wales. That's Phil again, and it's paper 3.4.
Thank you, Chair. So this report gives an update on the Healthy Mid and West Wales strategy, but also the important development that we've received the Nuffield report from Welsh Government, and you'll see there the accompanying letter from the Deputy Chief Exec, the NHS in Wales. You'll note that in the letter he states that the report is shared to solely to support the development of the strategic outline case that we've been working on. You'll see in the S-bar the timelines that we've been working to through over the last couple of years. I think you'll note that the Nuffield report is broadly supportive of our strategy that we agreed back in 2018, which I think is reassuring. However, it does offer some helpful challenge, and I think we also need to recognise that that strategy was agreed back in 2018, and as the Chair has suggested, does need to be refreshed and tested to see if it is right for the current world. We've had COVID intervening, and 6 years have elapsed since then. So we do need to make sure it's infused with the latest thinking, but also the current challenges that the Health Board faces and our newer understanding of the future challenges that we're likely to face. You'll see also that we had the team had a constructive meeting on the 22nd of April with Welsh Government, and we intend to report back progress on that and conclusions around that into our SDOD committee, Strategic Development, Organisation Development Committee, and then to board.
Okay, thank you. Any questions? Maynard.
Thank you, Chair. Yeah, it's particularly that last point about the SOC. I understand the meeting was very constructive, but there is considerable extra work that needs to be done over and above the stock work that's already happened. One of the peculiarities of the health service is that development of things like SOC can be funded from capital monies rather than revenue. I was just wondering whether Welsh Government have indicated that we provided any extra capital to fund that significant extra work that we've been asked to undertake.
Yeah, so it's a good point, Maynard, and my understanding is that we're still in discussion. That's part of the discussion with them, because there'll be discussions over the funding of it, the extra work, the scale of the extra work, and also the capability, capacity to do that work, and then the timelines. So that is the nature of the discussions that we're having with Welsh Government, just to make sure that it's proportionate.
Thank you.
Thank you. Anna.
Yeah, thanks, Chair. I guess I've got another sort of question that's time related. I mean, I think the rigour here that is being advocated is really important, although I guess we have to recognise that at whatever moment one ever presses a button on a major capital investment, it's redundant the moment it's agreed, and that is the nature of the business we're in. But I suppose more immediately than that, there is implicit within this, I think, an assumption that what we've currently got has got sufficient life in it for these various further actions to be taken forward. And I think any of us who set foot inside of any number of our major sites across our 3 counties will know that that is a questionable assumption, to say the very least. So I think while the rigour is to be encouraged, we also need to hold in mind just how fragile our physical estate is and the service pathways that are largely defined currently by that physical estate. And I wondered, Phil, if you might say something about that, please.
Yeah, thank you, Anna. And I think the Nuffield report really does recognise the drivers for change that we set out, I think, really clearly, working with our public and staff back in 2018. And in fact, that work, of course, was undertaken through 2016, 17 and 18. So those drivers for change are deep-rooted within our system and exist today, and if anything, are even stronger at this point, as we predicted they would be. At this point in the strategy. The other thing, the Nuffield report, I think, does agree that the changes we proposed are sensible and are really driven, as you said, by those significant estates and infrastructure fragilities that our staff and public and we see on a day-to-day basis hamper the way that staff really working so hard to provide high quality outcomes and experience for our population, and also hampers our recruitment campaign. So all of those things, you know, I agree. We have to, though, so we have to want to really work with Welsh Government around those challenges, but we do have to make progress in the meantime as well, because we can't just wait until a new hospital is built. We have to make progress on the things we can make progress on in the intervening time. So we need to be able to do both. We're a big health board, and I realise that's a big challenge, but that is our task.
Okay, thank you very much, Phil. So if there's no more questions, the recommendations are there to note. So thank you very much, Phil. Thank you for taking us through those very important areas. I'm going to now suggest we have a break for coffee. So it's coming up to 11 o'clock. So if we can break until 11:15, back ready to start. Okay, thank you very much, everyone. Welcome back to the meeting. So I'm going to move straight on with the agenda, and we're up to item 3.5, which is the financial report for month 12 and month 1. I think you're going to take the items together. Thank you.
Diolch, Cadeirydd. So just in terms of the month 12 position and mainly just for the record for month 12, recognising that month 1 is what we want to spend our time focused on today. But the position as recorded there is unaudited at this stage. We're going through the audit process now, and that will go through and report into the audit committee and on to the board when we approve the accounts. But the position on our revenue deficit is a 65.8 million deficit versus a forecast of 66 million, so came in just slightly below the forecast, but clearly significantly above the target control total of 44.8 million. And of course it means that we've breached our statutory duty in respect of our revenue, as we will all be aware. Cash position, we managed that in line with the cash allocation that we had. We had an additional amount of strategic cash support from Welsh Government, recognising our deficit, and that allowed us to continue to pay our invoices and pay our liabilities as they fell due towards the end of the year. Capital was underspent by a fairly nominal £32,000, so we kept within our capital resource limit, which is another statutory requirement for us. And one of the concerns clearly coming through the run rate charts is the continued reliance on agency, and that's a pressure that we're now seeing continuing into this year. So good work done to manage our agency use down from the peak at the end of Q1, but there has been an uptick towards the end of Q4. And forgive me, the graphs aren't showing on that section of month 12, but they're replicated in the month 1 position, and we'll come on to that. Clearly, the impact of that has then been felt on the month 1 position. So I'll probably pause there and then move on to the month 1 position, and then we'll open it up to questions at that stage. So in terms of the month 1 position, our planned deficit, if one can plan a deficit, is a deficit of £64 million for this financial year, which is pretty much a stabilisation of that 65.8 million starting position that we have. But against that, there is a savings requirement of 32.4 million in order to get to that figure. At this point in time, only 8.4 million of green and amber rated savings have been identified. That gives us a very significant gap of 24 million. The impact of that in month 1 means that there was an undelivered savings requirement of 2.1 million reported in that month 1 position. But we've seen 1.5 million of underspends in a number of other directorates. So it means that we're only 0.6 million off the plan in relation to the balance of savings and underspending directorates. So that gives us an overspend of 5.9 million in month 1 versus what would be required, which would be the 5.3 million to get us to 64 million. Absolutely recognise that's not good enough for us as a health board, and I want to re-emphasise the challenge that we've got that picks up the conversation from the annual plan discussion we had a few moments ago. There's an urgent need immediately to look at how do we convert the 8.5 million of savings plans that are currently red and black in their status into credible and deliverable savings that we can have to de-risk the financial plan. That's work that's ongoing at this point in time. In terms of our position for the end of the year, we clearly have a risk against the 64 million deficit, and that's represented by the savings that we haven't seen coming through at this stage. Very conscious of the cash consequences of this. I keep coming back to cash because that will become a very tricky challenge for us as we get towards Q4, and likely to hit us as an impact if unmitigated or unsupported by Welsh Government in February, March time, we will need that cash support and assistance. In terms of areas then of operational concern and operational challenges that we've got, I've highlighted two areas in particular there. Glangwili, there were a number of areas driving an overspend on top of the base budget that was allocated, and you recall from conversations we had when we approved the plan that Glangwili was the recipient of a significant level of additional funding coming into this year. So this is another increase in their expenditure that they've experienced. The factors contributing to that are mainly around agency use. They've got a higher level of substantive registered nurse numbers within the directorate, and they've experienced some operational pressures on flow in particular, and acuity, which has driven further use of nurse agency. There has been some targeted work. I'm grateful to the Director of Nursing for supporting the Directorate with looking at the effective use of nursing and working within safe staffing levels, and while doing that, reducing the number of agency workers being used. I believe that there has been a general reduction in month 2, but fairly nominal in its scale of nurse agency workers, and that needs to be maintained and continued. The other challenge that we saw within Glangwili was drugs and medication, and grateful to support of Chris Brown in Medicines Management for supporting the Directorate to address some of those challenges. Withybush, there were some significant factors there affected, not in terms of base budget, but in terms of delivery of savings that had already been assumed within their position, mainly around bed configuration and the challenges that they've experienced in the front door with increased ED demand and higher medical agency costs, and they're working on pushing through with the implementation of ward changes to drive improved performance and reduce agency demand in Withybush. In terms of our actions as an executive, we have a number of things that have happened over the last few months. Firstly, the accountability letters have been issued to all the executive directors now, with savings targets clearly identified within those. Recognise that we've had a board seminar where we've gone through the plan, and we will have further conversations and iterations of our financial recovery actions that we need to take in committee and in the board seminar in June. The Value and Sustainability Group has been set up alongside the IQFPD to maintain a focus on the improvements that we need to make. And we've also put in an escalation framework which is referenced in the IPAR. And I just draw your attention to page 509 of the pack, which includes a summary of the escalation statuses. So we have 26 separate directorates as cost centres that we recognise, and there are 3 escalation levels that are now in place. Level 1 being no concern, no escalation. Level 2 being limited assurance on delivery, and level 3 being no assurance on delivery. We have 11 directorates at the end of month 1 in level 1. We have 5 directorates at level 2, and we have 10 directorates at level 3. So there is a very significant concern over those 10 directorates. Meetings are in the diary. We'll be meeting over the coming week or so with a number of those directorates to understand the actions that they are taking locally to de-risk their position and identify their savings requirements. Chair, at that point, I'll probably pause and open up for discussion.
Right. Winston, do you want to come in first?
Yeah, thank you, Hugh, for that. I just want to comment on month 12, first of all. I think whilst the last year was quite a challenging year for the Health Board, I think there's some good points and some lessons to be learned. The good points are that we actually delivered £15 million worth of savings, and I don't recall that we've ever achieved that level of savings ever, so I think there's some merit to be taken from that. And the other area I'd like to just bring out is on the transparency of reporting. you can clearly see how directors have done against budgets, and I think that's a really, really good thing in terms of the board and the public. In relation to last year as well, I think we took a long time to identify all the saving schemes that we needed to, and I think that's a lesson that we need to take into this year. So noting, just linking it to month one, I note that of the total savings of 32.4 million, we've only actually identified schemes up to a smidgen of that, and I think that's got to be something that we really focus in on as soon as possible, both non-recurrent and recurrent schemes. My concern is in relation to, I think Hugh mentioned that there were 10 directors at level 3.
Yeah.
And I just want to understand the extent to which all budget holders have signed off their budgets. How many have, how many haven't, and what are we going to do about it if they haven't?
Thank you. Hugh, do you want to address
Yeah,
those?
thank you. I'll start with the last questions around accountability letters and signing off budgets. So all bar one have now been signed off. That one has been purely just because of leave, and I'm confident that we'll be able to reach a consensus and a conclusion on that over the coming week, 10 days, in order to close that issue off. It's a disappointment that we're at the end of month 2 with that one lingering, but we will address that. Savings identification is the real challenge for us this year, as it has been for a number of years in the past. I think there are 2 fundamental challenges that we have really struggled with over the past few years. The first is cost containment. So we've seen that continual increase in our cost base, particularly, as I mentioned, when we approved the plan in our sites and within unscheduled care within our sites. So that's a real area of focus for us, hence the escalation framework kicking in to make sure that we can put grip and control in around that. And secondly, then, the identification of savings. We've now got a robust opportunities framework, which has been shared with our operational colleagues and budget managers across the Health Board. That doesn't cover all of our services, but it gives us a good enough view into where our inefficiencies lie. And I'm pleased with the engagement we're getting on that. The challenge isn't the engagement on the opportunities, but the challenge is converting those then into deliverable actions that will reduce our spend.
Okay, thank you.
I do want to come back.
Do you want to come back?
Yeah, just a couple of things. So I think here in your report you've identified concern about Glangwilly and Withybush, and I'm concerned about those as well, especially in relation to the apparent increase to agency and locum costs. Are you confident that the actions we're going to take are going to try to resolve those, or is this something that you think it's going to be a recurring theme during the year? And I'm minded to think about what's in the annual plan in relation to how we shift resources from secondary to community, and whether there's a link to the pressures on those 2 particular hospitals in our system.
Yeah, so both are different issues. So the first issue in terms of Glangwilly is performance against base budget without delivering savings, and that's a concern because that's clearly unacceptable for us to be in that position. And as I say, I've had support from Medical Director, Director of Nursing in particular, to support the Directorate to improve that position. I don't know at this stage whether that will recover fully in month 2, and we will find that out in the next couple of days. But the Directorate have been escalated. They're at level 3, and they will be coming through to a meeting next week to understand and to provide greater assurance over their delivery trajectory for this year. Withybush, the issue there is delivery of savings, and some of the pressures that they've seen there that have mitigated what they had assumed would have been delivered. So it's a slightly different cause for concern there. And again, Withybush have been escalated, and we'll pick that up through the process next week.
I think Andrew wants to come in on this point. So, Andrew, can I bring you in?
Thank you, Chair. I think just to try and give some reassurance as well. I think obviously the month 1 positions challenge, we were disappointed to see where the 2 areas that we've highlighted ended up in April. I think there's a couple of things we probably should stress though. The increased spend was an increase on the position at the time the budget was set in November, or identified, baseline was identified in November, and the increase represented, as you'll see in the performance report, the significant levels of pressure and demand that were being seen across the system through December, January, February and March. And going into April, although they were still off their budget, they were showing a reduced level of expenditure than they'd shown in the previous 3 months. So there were clearly moves in the right direction. To add to that, I think we had on our savings scheme last year, for most of the year, the closure of Ilova, which was an unfunded surged ward area. They closed that by the first week of April. So I think there is a different, whilst there's still a challenge and there's a significant amount of work for them to do to deliver a savings plan that covers the level of savings required of them in this year, there are signs that there is a different approach, I think, to addressing some of that challenge and the urgency around addressing some of that challenge. And as Hugh said, they've responded, the areas have responded well to the additional scrutiny and help and support they've had over the last 4 weeks to try and get further grip on those issues that were causing us concern in April. So just wanted to stress that I think there is a seriousness being taken to the position in month one that perhaps we haven't seen in previous years, I would suggest.
Thank you, Andrew. Rodri.
Okay, thank you. On the same point as Winston, but so if we're looking at the papers on the slide deck, I have to say, I've said this before, but the papers are very informative and they have been laid out in a very easy way to read. Just back to the medical locum expenditure, because if you look at that graph, it says the latest data is showing a concerning trend. We've discussed this in ARAC as well, but have we got that assurance that the use of premium cost locums are on the way down? Because that has been an issue, and I know I'm raising something that's already been raised, but I think it's a question that we need assurance of. The premium cost locums are very, very expensive, aren't they? So,
who wants to come in on that? Mark?
Yeah, thanks, Rodri. Agree totally, and I think we have had a new focus on it and have had, in inverted commas, some success recently in that space. So I can assure you that the premium cost locums will be reducing in number. I can't share the details of that, but I'm having a particular focus on that.
Thank you. It's reassuring to hear that, and thanks.
Thank you. I've got Michael, then Eleanor.
Thank you, Chair. I'd like to echo what people say about the transparency of the report. It's very helpful. Just a query on, just a little point of information, if you could. One of the main mitigations is the value and sustainability group, isn't it? As you mentioned, that's number 1 in the list. Just give me a little bit more of a flavour of who's that, and what exactly are they, they're doing at the moment. Just because that's obviously quite an important feature in what we're trying to do.
I think, Lisa, do you want to come in on that? You chair that group.
Yeah, so between myself, so I'm the chair of that group, Hugh is the vice chair of that group, so we will be overseeing all of the work that's coming in through Welsh Government with their value and sustainability schemes. We've also got the opportunities framework that our finance colleagues have drawn together around how we compare with the rest of Wales and beyond. And also then we'll be overseeing the health board-wide savings programme. So if anything's been introduced, so nurse overseas recruitment, for example, will impact on the whole organisation, they will come through this group. And then there's a close association with the IQ FPD group that Andrew chairs in terms of when some of those schemes get worked up into the detail and become an operational issue, Andrew will then take over those work streams for the delivery with the services.
Okay, thank you. Eleanor.
Thank you. 2 points. One, to say thank you for the quality of the paper. It really helps to be able to see so much transparency. And also thank you to the people out there who've gone ahead and made some savings and put schemes forward. It's not easy when you're busy and so much else is going on. The next bit is not such a pleasant thing to say. Whilst I really, really appreciate all the hard work, the run rate is such that we're not going to make it. That worries me as a board member, and I know it worries the executive as well. What can we do? What can people do to inject some pace to make these savings happen? Because if we don't, we're going to have to make more difficult decisions than we need to in order to catch up on the money.
Hugh, let's come in on that.
Yeah, thank you. Yes, it's a challenging position, and I'd agree with the run rate not being where we need it to be. There has been a step change in engagement on the money, and I am pleased with the response from colleagues around this table within the executive. It feels like we are all in this together, and we're all focused on reducing our expenditure and eliminating waste harm variation. And Andrew mentioned it. I think that's replicated across budget managers across the organisation. There will always be challenges in certain areas, and there will always be issues, of course, in certain areas. But there is a notable change in the tone of the response that I'm receiving. Escalation, as we know, going into escalation as a health board is an unpleasant experience for us as a board. And I know that that feeling has been replicated in directorates that have been escalated internally. We have our first set of meetings coming up next week, and that will be our first opportunity to explore, understand what are the issues preventing savings from being delivered, and then overcoming those. That's at a, if you like, the directorate level. The work that I think corporately then we're pulling together in terms of what does the financial roadmap look like, what does the scale of change need to look like, I think is something that we will be picking up as executives and as board in conversations over the coming month as we seek to de-risk the plan, and I think that will support. One of what the question was asked earlier about the agency medical position, and that is a particular challenge for us, and one swallow doesn't make a summer, and we probably know that this summer more than any. But on page 407, you can see there very clearly that there has been a very significant reduction that we've seen in month one. That is a real reduction that we've seen in month one. Whether that can be sustained or not, time will tell, and we will come back to that. But there has been a reduction. We've also seen a reduction, and you can see it there in the nurse agency expenditure. There was that uptick in the end of last quarter. That has then reduced somewhat in month one. The challenge for us is it didn't reduce sufficiently in Glangwili compared to where we were in November, December when we take the budget cut. So we are seeing some of those run rates showing the right level, the right direction. The challenge is the pace at which that's happening.
Thank you. And it's good to know there is that sea change, and that there is starting to be a focus on the culture change that's needed to do that. Diolch.
Thank you. I'd just like to ask one question. In terms of the explanations for both Glangwili and Withybush, both areas talk about the medically optimised patients. And I know the figures I saw this week showed, this is obviously for May, middle of May, showed we had 270 patients awaiting move to another way of providing care. And I know when I worked it out, quite a small percentage of those actually relate to health-related delays. We have a whole page of categories as to why patients are delayed, which I know that government are actually having a look at to see whether we need so many. But I just wonder, are we seeing any? I can't see any improvement particularly in that. And I know we've got so many schemes and initiatives, but where is that work going? How are we doing to try and change that picture? Maybe that's something I need Andrew to perhaps answer, but please.
I'll ask Andrew and Jill, I'm sure, to come in and comment, but we've seen now the census day count increase for the fourth month, I think it is. So there were 237 delays that were counted at the end of April, of which 155 were acute patients ready to leave. So there's a very significant challenge that we have there, and that's part of the flow challenge that we've got more generally. I'm sure Andrew will have more to say.
And I'm asking that question, I know we're talking about finance, but I'm thinking about the care of the patients. They're in the wrong place.
Yeah, absolutely.
So it's about that quality side of things. So Andrew, can you your comments on that?
No, I think it's continuing to be a really challenging issue for us across the region. I think there are probably different factors in different systems of counties for the reasons and what's causing it, but I think we can't escape the fact that our local authority partners are having some similar challenges around workforce and staffing. I know receiving an update from Carmarthenshire just over the course of the last week, they were articulating that they'd seen a significant challenge in terms of available workforce to provide care in the community, that they had seen an increase through last autumn when we saw our numbers improving, and we had seen them improving for a number of months through last year. But then some of those staff left, some of that capacity was lost, and it's taken some time to get back to a place whereby they've got back to where they were. I think they're anticipating, certainly Carmarthenshire are anticipating some improvement as those numbers have increased. So I'm expecting to see some improvement there over the course of the next cycle. I think Pembrokeshire, which is the other sizable challenges, are a different set of issues. We know we've had through our regional conversations capacity challenges. There they have. I know it's something that they are really concerned about and are taking very seriously, and they've got a new Vanguard improvement programme to look at how they increase capacity and flow, both in terms of patients in hospital, but also their concerns around patients waiting in the community as well, both of which will no doubt have an impact and benefit to us from a health perspective, but that work's just commencing, but will be linked in heavily to some of the work in improvement work we've been doing within the system in Pembrokeshire from a health perspective as well. But it is a significant challenge to us in terms of our available capacity, as you're rightly pointing out, Chair.
Yeah. Okay, sure, it's something that will be monitored over the year, and particularly looking at it from the quality of the care, not the care given to those people, which I know is excellent. It's the fact that they will deteriorate while they're in our hospital beds, which then brings on all sorts of other challenges further down the line, and nobody's aware of that, but I think it really does need to be a focus. Okay, thank you. I can't see any more questions. I think, Hugh, there was some concern about recommendations, which felt a little bit passive, if I put it like that, and I understand you would like to make some suggested changes to those.
Yes, Chair. I think I'd agree with that. In retrospect, I don't think the passiveness of the recommendation reflects the actions that we're taking as an organisation, and I'd like to give the board that level of assurance. I think now that we have the revised ways of escalating and assuring from committees into the board with the 3A approach, I'd like to take that opportunity to then reflect on what are the recommendations we put into our board reports more generally, because in reading board reports, actually, we do tend to keep to either note, discuss or approve. Well, there's a whole range of other recommendations I think we can consider. So I'll reflect on that and maybe with the support of the Director of Corporate Governance, we can pick up what will be the menu of recommendations we can think of that we can then provide further kind of action-orientated recommendations to the board.
Thank you. Are the board content to accept that explanation going forward? Thank you. Thank you very much, Hugh, for that. Okay, so I'll move us on now to item 3.6, which is the improving patient service user experience. Sharon.
Thank you, Chair. So this report covers the period from February to March of this year. I know you'll have had an opportunity to read it. I just wanted to pull out some highlights, really. You know, I just want to thank our patients and service users for their responses. Over 6,000 patients have responded on this occasion. And also to call out the 95% almost have reported good or very good experience, but it's important to consider the experience of the remaining 5%, I think, who did score less positively, and a lot of those comments are included within the report. There are two areas that I've asked the Improving Feedback team to consider and to progress as a consequence of the findings within the report. One was we discussed last board meeting in terms of patient experience in primary care, and it was just to pull out, it's included towards the end of the report, that current patient experience surveys are conducted by the practices, and there's a requirement under the quality framework and the GMS contract to do this. Each practice is required to reflect on the feedback and to put in place actions to address the concerns. The feedback will form part of the discussion with each of the practices that we will follow up. And you'll note from the report that a few practices haven't returned the overall score yet, but this will be requested, and it will be discussed with individual practices at the meeting with the Health Board primary care teams. Just wanted to note as well that we are embarking on a pilot with Public Health Wales nationally to introduce Civica into primary care across the Health Board, commencing with the managed practices. So we've not achieved that elsewhere in Wales yet, so it'll be a priority for us this year going forward. In terms of the learning from feedback, I'd like to thank the patient who provided the story and for going back through his journey. And I'd also like to thank the Cancer Services team for their response to this story as well. And I hope that the initiatives that are outlined in the report, such as the triage line and the access to SDEC and establishment of patient-reported experience measures, will contribute to improved experience for current and future patients on their journeys. And this will be the focus of our Learning from Events subcommittee in July as well. I'd also like to thank Claes as well. I can see on the agenda later on today there's a report for information, and I just interested to note the congruence between the patient experience report and the findings in your report as well. And I know that I've got a meeting with Sam in July to run through that report as well. And the only other thing I'd like to pull out, Chair, is the reflecting really on what Ewan called out earlier in terms of how we're harnessing local talent and connecting with our communities, and to thank our Vice Chair as well, who chaired the launch of our Arts and Health Charter this month. Diolch yn fawr, Eleanor. It was very well supported and recognised across Wales, and I think included in the Welsh Government newsletter as well. So it's had good publicity. And I know that the Arts and Health Group will be meeting soon to commence that implementation. So thank you.
Thank you. Thank you very much, Sharon. Questions? Chantal.
Just one quick question. Thank you for the report, Sharon. It's just in relation to communication, because that's been a theme, and we hear that at the Listening and Learning Subcommittee as well, in terms of that. And I note that a new training package has been put into place. I just wondered at some point whether we can have the data of the number of people who are actually attending the training, so that we can see that actually there is, you know, whether there is a correlation between improvement in terms of how patients perceive how they're being communicated with, and the training requirements that staff are undertaking.
Yeah, fine. Yeah, that's fine, Chantal. And I think you're right that we are reviewing the training that we're delivering, but I think we're also trying to include compassionate conversations in some of the leadership and management training that we're delivering across the Health Board as well. So I think we need to be cognizant of the training figures in those areas as well, just to see how it's impacting. So we'll include that in future reports.
Okay, thanks.
Thank you. Anna.
Yeah, thanks, Chair. A couple of observations, if I may. I think the bit of analysis we've got this time round for the full year is helpful to see, and particularly on page 424, the top 5 specialties in terms of volume of complaints seems to mirror very closely the specialties within which we have particular access issues. And I think that really underlies the fact that, you know, in amongst all the detail that we see in this report, access is or lack of it, is a very significant driver for complaint and concern. And so I think it's just worth drawing that out, really. And the second observation, which might lead into a bit more of a question, the data around use of the Welsh language. So I'm looking on page 431, the graph there. Were you able to speak in Welsh to staff if you needed to? 70, let's say roughly 75% said that was a not applicable question. If we assume that those 75% are not first language Welsh speakers, and if we assume that the remaining 25% are, does that ratio, 25-75, roughly reflect our population? And if it doesn't, does it tell us we've got an issue with the accessibility of our survey work for Welsh speakers? And I know we have previously in engagement in a different context here, but in public engagement exercises, I think the last time we ran a big questionnaire, the responses that came back in Welsh were minute. You count them, I think, more or less on one hand. And yet we know that's not reflective of the population. So I'm just wondering if there's something here about the way in which we gather this data is inadvertently proving less than accessible to some of our population. I don't know, it's just a question.
Okay. It's an interesting question, and it's important in terms of equity, isn't it? And I don't know, if I'm honest with you, what percentage of our population are Welsh speakers. I would imagine it would be more than 25% in this part of the world.
That too,
yes, yeah. So it's how do we elicit that response? Or is there an assumption that individuals who do speak Welsh feel that they could answer the questionnaire in English as easily as they do in Welsh? And maybe that's something we need to explore a little bit further to in line with the requirements of the Welsh Language Act as well.
Oh, Anna, do you want to come in on that?
Yeah, I believe that the figures in terms of the percentage of Welsh speakers in our area is just under 37% of our total population. It obviously varies in terms of counties, with Ceredigion and Carmarthenshire having a higher population of Welsh speakers. But I think there's also an issue in the sense of confidence of Welsh speakers, particularly when it comes to talking in medical terms around things and being aware of what those terms are. However, as a health board and as a public sector organisation, we obviously have a responsibility in terms of providing that service to our community, and particularly within the health sector, having the active offer. So it's not waiting for a patient to request, but having that just a shwmai or hello, just to open that door so that people feel that they can start a conversation. And even if the member of staff can't respond in Welsh, that they understand how they can go to a colleague for support. And as a health board, we have a number of supporting programmes for our staff, including the Welsh Language Confidence Officer that works with our staff to help individuals in improving their skills, even if it's just a bore da, a shwmai, or know how to access services. So it's work in progress, I'd say.
Thank you for that. Do you want to come in that before I bring in Rodri?
Yes, just on that point, as the Welsh language champion, I suggest we take that back to our Welsh language team to really drill down on this information, because we all know that we have got pockets of our Welsh speaking communities, but it is, as Alwena says, the confidence. So I think we'll take it to that Welsh language team to really drill down. Thank you.
Is this the same point, Donna? Because I've got someone waiting.
Just to advise, we're in early stages of discussion in Palace about looking at exactly this issue in the Eisteddfod in August, and that is looking at people accessing Welsh healthcare in the language of Welsh. So there may be a piece of work that we can share with you later towards the autumn.
That's very helpful. Thank you for that. Thank you. Rodri.
Yeah, well, catching up on what Anna said, but if you look at the ESPA, there is one thing. There's 39% of all concerns where, and it's quite consistent, is regarding clinical treatment and assessment. And I'm just thinking, what are the issues at the clinical assessment? I'm just thinking that stands out to me as 39% of all the complaints. And obviously, it's something that's consistent. It's not the first time we've seen that. And what are the kind of the big issues there? The 39%. It's quite a large kind of percentage of the overall. And I've looked at the kind of appendices to that. But I'm just thinking, I don't know, perhaps Mark, what's your take on that kind of the 39%?
I guess it's obviously multifactorial in terms of what people think of what clinical assessment means. It could be the quality of that, the timeliness of that, the seniority of the person that you see, and the outcome of that, and did it meet your expectations? So that's what I read into that. So I think it's a really good point that somehow we're missing, I think, as we're not fulfilling people's expectations is how I interpret that. But then you link that to how many people are content with the services that we provide. So it's something, I think, it's a very good point, Rodri, that we need to understand a lot more what we mean by that. I don't know, Sharon, if you know what we actually mean by that.
No, I think you're right, Mark. I think it is multifactorial, but I think linking back to what Anna was saying around the trend data, accessibility is definitely an issue in there. So I think that's, and the areas that are highlighted in that chart probably, you know, contribute to that. So I think there's probably some work that we could do to understand that better and pull out a bit more detail. And
I think that's where I was coming from. If you've got a 39%, I think we need to be quite clear of what people think and kind of just so that we can learn from it and move forward.
Sure. Thank you. Anne.
I'd like to thank, on behalf of us, the staff at Withybush Hospital for another successful patient wedding. It's really heartwarming to see how good they are at that now.
Yeah.
So thank them for us.
Will do.
Thank you.
Thank you, Anne.
Thank you. Yes, it's lovely to see after, and I'm glad that one seemed to be a little easier to organise. I understand, because somebody set the ground rules for how to do it. So thank you, Eleanor.
Very brief comment on the word cloud that was developed around the mental. Again, I'll learn at some point. I just wanted to acknowledge the word cloud that had been created from the feedback from the Mental Health Service, with the words that are coming out at the top of kindness and excellent and friendly. That's really important, and you know, all credit to our staff for that. It's a really positive comment, and having drawn that out, there are very few negative words in that word cloud, which is really nice to see. So that's a thank you from me from the board for that.
Talking about.
Thank you very much. Phil, do you want to come in on that? Sorry.
No, was there somebody else who needed to come in?
No.
No, okay. So actually I was going to go back to the comment that Anna made about the complaints received by specialty, which I think is a really salient slide. So, and the top one is the accident and emergency, so the emergency department. So we could interpret that as there being just more numbers coming through our EDs, but we will know, all board members who've visited EDs, as most of us will have done, just the significant challenges that our staff and public are facing in our EDs at the moment. Myself, the Chief Operating Officer, Medical Director and Nurse Director met with the senior ED consultants from across Bronglais, Withybush and Glangwili yesterday, as well as the senior nurses from those sites, at their request actually last night, just because of the significant challenges as they see them. And I have to say, you couldn't help but be really proud of the work that they do, but also the professionalism and the ideas and energy that they still had to tried to work with us to try and improve the outcomes and experiences of our population who attend EDs. So they do have lots of ideas. We also had the lead emergency department consultant across Wales with us in that meeting. So I know Andrew, Mark and Sharon will be picking that up with the ED consultants, trying to learn from where people have made progress across the UK, in fact, in ED. So it is going to need to be a significant piece of work because we've known for some time that it's not the kind of environment that we want it to be at the moment.
Thank you. That's really helpful to say that, because I had a recent visit to ED, as you know, in Withybush, and I think the enthusiasm of people to come up with solutions is really palpable, and it is just harnessing that. And I'd also say that with the new ward at Withybush, it does show what is possible within a new environment, and the way that's working is just, you know, really positive. And just the simple thing of having very wide corridors that you can actually move everything down is just it makes such a difference to staff. So I think, yeah, that's really good news to hear that going forward. Thank you very much. So the report is there. We've received it and discussed it. Thank you, Sharon, and thank you to the team for pull that together. So I'm now moves on to the delivery section of the agenda. And the first item is 4.1, which is the integrated performance report, both for month 12 and also month 1. Hugh.
Yeah, Dr. Cadeirydd, and like the finance report, I'll just keep the month 12 position brief and then go into a bit more detail on the month 1 position. Just 3 areas I want to pull out on the month 12 around planned care performance at the end of the year and the improvement that we've seen there. I'm very conscious that in talking about improvement, there are still people waiting far too long, and against every statistic that we measure here, there are people waiting at the end of those statistics. But it is heartening to see that the RTT breaches over 2 years, so the referral to treatment breaches, are below 1,500 people waiting for the first time since August 2021. So that is a notable improvement that we have seen. The number of patients waiting over 3 years, we had an ambition for no one to wait over 3 years, except for orthopaedics, which we recognise is a challenge. We didn't achieve that because there were 9 patients waiting for vascular surgery over 3 years. Over 2 years, the ambition was to have fewer than 1,700 patients waiting. We achieved that with 1,458 patients waiting. And for new outpatients waits over a year across all specialties, our ambition was to have 4,200 patients, or fewer than 4,200 patients waiting, and we achieved that with less than 3,500 patients waiting. In diagnostics, we've also seen a very significant reduction towards month 12. 3,699 patients breaching, which is the lowest level since April 2020. And we saw improvements across radiology, endoscopy, neurophysiology and cardiology, improving that position. And in cancer, just to pull out the position for us at the end of March was a performance of 60% against the single cancer pathway. Again, our highest performance since October 2021, but the backlog continued to increase with some diagnostic challenges impacting lower GI, urology and gynecology. So with that, I'll just move into month 1, if I may, Chair. The cancer information as at March is the latest we have, so there's no update for cancer for month 1. But in terms of some positive news in month 1, mental health, we have been above target and trajectory for children and adults undertaking a mental health assessment within 28 days. And it's worth noting that improvement. And the 26-week target for adults starting a psychological therapy, while below target, has exceeded the trajectory, so that is positive. Challenges quite naturally across urgent and emergency care, given the previous conversations we've been having. Ambulance handovers over an hour, over 4 hour, ED waits between 4 and 12 hour, and breaches in those spaces are continuing to show concerning variation, and challenges as well understood and documented in terms of acuity, hospital flow, and high numbers of clinically optimised patients that we are seeing. Within mental health services, the 26-week target for children starting neurodevelopment assessment has been a challenge for us, and adults waiting less than 26 weeks for psychological therapy are now below target and demonstrating special cause concerning variation. Within planned care, despite the good performance that we saw to the end of March, the breaches did increase between March and April across all outpatient and RTT metrics. And in diagnostics, a similar issue, despite significant reductions in February and March, we saw breaches again increasing in April. All services except cardiology and imaging deteriorated in April. And patient falls of concern, we saw a high number of patient fall incidents reported in March. Prince Philip was the site with the largest increase relative to the size of that hospital. We've already talked about delayed pathways. Just one area of note where we have changed the way in which we capture data is within therapies, where the data excludes audiology and weight management services now, because that's not the way in which we capture that information for reporting against those targets to Welsh Government. Clearly the weights are still a concern within those services, but it's not a metric that we capture for Welsh Government. Just to reference the appendices that we've got as well. So Appendix A on the month 1 represents the performance against the measures we're capturing against our targeted intervention framework. Appendix B demonstrates our internal escalation framework across the domains that we are measuring against. And Appendix C and D, the team have started to provide a deep dive, which I hope will be helpful for board members and members of ESTOD in the meantime, around areas of concern each month that we'll be presenting. And in the last meeting of ESTOD, we had the single cancer pathway performance, which I've included in the pack. And this month for the board, our performance against mental health measures, just as a deep dive to help understand that position a bit better. So Chair, with that, happy to open to questions.
Before I open it up, I'm going to bring Andrew in.
Chair, I suppose just a couple of things that tie into the last conversation. So firstly, I think you can see through the month 12 report, and I believe with our plan for this year around planned care, cancer diagnostics, we'll continue to see progress towards the delivery expectations that Welsh Government continue to set and push us to deliver. And I've got some confidence in the plans and work we've done around delivering those. Mental health, again, we've seen some significant improvement in some areas, but recognise that in a couple of areas we're still struggling, as are most organisations, around neurodevelopmental pathways and services. It should be said, so there's definitely more work for us to do there. I think I guess the point I just wanted to make was, I think, built on what Phil, as Chief Executive, was saying on the last item and the conversation with ED consultants. Our urgent emergency care performance, as we look forward through this year, both in terms of what we set out in our annual plan and the further improvements Welsh Government are expecting us to deliver on what we originally set out in our annual plan, are going to be challenging. I think there are some green shoots in May around some of the high-level indicators, particularly ambulance handover delays. As of midday yesterday, it looked like we will have our best performance probably since sometime before Christmas. But 12 hours will not have improved from where we've been over the last couple of months. And so there is a significant piece of improvement work that we need to progress there. And in doing so, not only will it improve our performance, I do believe it will have a material impact on our financial challenge and pressures as well, because so much of our in-month financial variable pay cost is driven by the demand and pressure on the system. So the better we perform, the better that will look. I think a special note as well in that to say that the most significant improvement through May has been at Withybush since they've been able to bring back online the capacity they plan to this year following the impact of RAC and the way they've reconfigured services there. We have seen a significant improvement in performance at that site. There's much to do though across the health board and still in Pembrokeshire to get us to a place whereby I would feel comfortable sitting here, and I don't think I'll be saying this for a while, but comfortable sitting here saying we're delivering a level service that I think is acceptable for our population and for any of our friends or family. So there's much to do and a lot of focus. I'm grateful to the work. I think Peter's still in the room. I'm grateful for the extra support Peter's been providing on top of his day job to help pull together a bit of a refresh of our 6 goals delivery programme for this year, which I think is going to be critical to all of that.
Thank you, Andrew. And Peter, thank you for taking that challenge on. Thank you. Right, any questions from anyone? Got Anna and Maynard.
Yeah, just a clarification on the colonoscopy position, which is on page 5 of the report. So I don't know if I'm sort of reading this wrong, but it says the service actually delivers on average 5.5 lists per week. And with that 5.5 lists, we're reaching 23.9% of patients. Is that a correct interpretation? And if so, increasing it by a couple of extra lists a month is surely not going to close that gap between 23.9 and the target of 90%. I think I must be misunderstanding something there.
Okay, can anyone help? Andrew?
I'm not sure that there's that direct correlation in that way. I think the list reflects as well the increasing capacity we need to reduce the number of patients waiting over 8 weeks for endoscopy as well. So there's a couple of factors in there. If you let me take that away, I know I'll get some clarity on that for you, just to make sure that we're describing that as intended.
Okay, I think Mark, you might be able to help
yeah,
with
what
that.
we're describing as bowel screening, so not our symptomatic lists.
Okay.
So that's the
Right.
difference. So obviously we deliver a lot more, probably, deliver 2 lists a day per room of colonoscopy. So this is just specifically bowel screening.
Okay.
So that's the 5.5 is extra, bowel screening.
Okay, maybe next time we could just maybe express this in a slightly different way. Okay, thank you. Maynard.
Yeah, thanks for the report. Just a comment that the report seemed to be getting better in the provision of information, particularly the deep dives. Really useful to be able to see the data behind some of the comments. On page 5 of the report, the 2 mental health measures causes of concern, we're talking about purchasing additional capacity from external providers in order to undertake ASD assessments. We're obviously receiving 109 referrals per month, and we're only able to undertake 26 to 28 internally. So that's quite a significant gap. But my concern is about how are we ensuring the quality of the external providers. Many people watching and many people around the table will have seen the recent Panorama programme about ASD assessments being done online in half an hour. And that's obviously not sufficient quality. So I'm just concerned that how are we avoiding poor quality assessments?
If I might, I was exactly the same.
Oh, okay.
Thank you, Chair. It's exactly the same area, and Maynard has asked some of the questions that I was going to ask. My additional ones are, if we're only seeing about 14% in 26 weeks, that's about 450 of the 3,000, what's the impact on the patient and how are we dealing with that going forward, and is it a quality area? The other one for me, it was, how does this compare across Wales, and are we ahead or behind in those stakes? And what's the patient experience going through that when they're having to wait so long?
Thank you. So quite a lot around ASD. Andrew, can you pick up those questions, please?
Yeah, I'll try to, Chair. So I think in response to Maynard's question first, I think one of the reasons for us that the additional capacity is providing relatively so few appointments compared to the demand we've got coming through is because of the length of time and the number of contacts that individuals need. So I certainly know that those appointments aren't 30-minute online appointments as such. There's a much more lengthy consultation and number of consultations. So I think if I would almost, with the model we've got there, if we were seeing more than that at the moment, that would lead me to think that the level of quality of the outsourced provision was not what we'd want it to be. But I will ask through the directorate that we make sure we properly monitor and capture that, and I might suggest if it's appropriate to the chair of Quality and Safety Committee and to Sharon as Director of Quality and Patient Safety and Experience, and maybe we at some point through the year takes a paper to that committee that provides some assurance around the quality of that procured service. We've obviously got a significant shortfall, and we've got a number of patients waiting a long time, up around 4 years in some cases, which clearly isn't acceptable. There are mitigating measures in place, so the use of things like Kooth as a counselling tool that we give patients access to whilst they're waiting, to provide support whilst they're waiting for their consultation. And we know that from a Welsh Government perspective, neurodevelopmental services is seen as a problem across all health boards, where nobody's doing it particularly successfully because of the demand and capacity gap, and they're working through what a more strategic solution to that challenge might be at a national level, which we're obviously engaged in and plugged into. So I don't think we're any worse. We certainly won't be any better than anyone else. I don't think we're significantly worse than anyone else, but I don't take any comfort in that, because I'm aware that we're not offering a level of access or a level of service that the population, that meets the needs of the population at this point. So I have had a couple of other providers of workforce come forward to me over the last couple of weeks who seem to think they may have opportunities to possibly help provide more capacity in this space, but I'll have to work through that with the directorate and colleagues in terms of any impact on our annual plan and financial plan for the year for mental health and LD as well. So there's a few things to consider, but there may be some other options emerging that might help provide a bit more capacity through the course of this year.
Okay, thank you. Okay, thanks. Okay, I'll make a note of that. Thank you. Rodri.
Yeah, I think it's more clarification. If you look at the key areas for improvement, and if you look at the March figures and then you look at the latest period for April, the figures for the waiting list for 52 weeks and 104 weeks, the figures have gone up 500 from understanding from March to April, but then the variation, if you look at the table, it's an improving trend. And I'm just thinking, should that kind of, I don't know, colour be perhaps concerning, or you see where I'm coming from? Because it's a month on month, and even though it's an improving trend, we're 500 kind of patients kind of worse than it was last time. I just wanted to know, at what point does that dial change colour?
Okay.
Yeah,
Hugh, you're going to...
That's probably to do with the maths that's driving the calculations. So it's a trend, so we don't take 1 month in isolation. So the deterioration in 1 month doesn't represent the trend that we're tracking against. So it is an improving trend, but it's a deterioration in month.
Okay, thanks. Winston.
Thank you, Chair. I just want to comment on the workforce figures and also in relation to also the escalation framework. So Appendix B, the escalation framework, which is on page 509, is really, really helpful, very, very helpful indeed. But when you delve down into the workforce figures, so our average workforce performance is 6.3%. We've set a target as a board of 4.8%. And the areas which are high are facilities at 10% in April, PPH at 9.3%, and Sarah Diggin at 8.2%. But in the escalation framework, we've only identified facilities. So I think we need to look again at that in terms of how we're doing. But in general, I think the comment about workforce and our sickness levels, I think they're just, I'm not convinced that we're doing enough in this area. I'm not convinced, and I think it's an area of opportunity for us to either make savings or at least make more utilisation of our workforce. So I'd just like some assurance as to what's being done about it.
Lisa, can you come on that, please?
Yes, certainly. So if I address first of all the escalation framework, in the workforce domain, there's more than just sickness absence that would drive that. So it is one of several elements, which is why there's only one directorate that has been escalated to the highest level. There are others where sickness has been raised as an issue. In terms of are we doing enough about it, I think you'll see the difference in the two reports is the short-term sickness dramatically changed in the first report, in the month one, compared to last time. So there's definitely a focus on the short-term sickness absence. In terms of the long-term sickness, we're working with our trade union representatives, and we've got a subgroup of our partnership forum to look at what things do we need to do to support our staff who are off with long-term sickness, because we have to remember our staff are our population, and therefore all the waiting lists that you are seeing here also impact upon our staff. So the conversations that we're having with our trade union reps is for those individuals who are in that position but want to return to work but cannot return to their substantive post. How do we get them back into the workforce so that actually they are able to continue in work? They're not reducing their pay as well in terms of sick pay. So there's a focused piece of work that we're doing with our partnership forum. We have a workshop session every other partnership forum. So in our August meeting, we'll see the progress that we're making around that. We have got a role within the workforce and OD team that supports sickness absence. And we're also looking at reprofiling how we undertake our audits. So the audits will focus upon process, but we're looking to see if we can change that approach to add more value.
Okay, thank you. I just have one question. It's just to clarify something. We know that Industrial Action had, Junior Doctor Industrial Action had an impact during last year, and can I just clarify the recent announcement around Industrial Action in June, is that England only in relation to junior doctors?
Yes, it is at the moment, yeah.
Right, okay, thank you very much.
Sorry, Chair. I've just got a question about delayed discharges, and when can we see an improvement in this? Because I notice Carmarthenshire and Pembrokeshire are still with high levels of delayed discharges, and there is a lot of work going on about trusted assessors. But when can we see an improvement?
Yeah, I think, Andrew, you touched on this earlier. Do you want to, is there any more you want to say?
I think that the trusted assessor question is an interesting one. It's one that I know Jill and I have been probing quite a lot over the last couple of months, really, because we reportedly have the highest number of trained trusted assessors of any health board of any health board in Wales, and yet we're not overtly seeing that benefit in terms of the number of delayed discharges coming down. I think there is a bit of I think there has been a reduction in some of the assessment delays as a result of those assessments, but that doesn't necessarily translate into additional capacity in the community to care for people either in social care or within our health settings. I think that's going to be, how we provide that care across the region through the regional partnership is going to have to be a key component of our urgent emergency care work this year, as it always is, but we've got to make some progress on it because those numbers can't keep, in my view, they can't keep increasing in the way they are, because they're just hampering our ability to work with, to be able to provide the level of care and quality that we want with the resources we've got available.
I think there is, just to add, because I was talking to one of the trusted assessors who also happens to be a qualified therapist, and there was some frustrations in terms of some of the limitations being put on what they were able to do. They felt they could actually do more, but there were certain restrictions, shall we say, from partners to being able to fully fulfil that role. But there are variations, I know, but I think it's something that perhaps also we will be reported through the Regional Partnership Board, which Roger obviously is a member there. So, but thank you, does need to be tracked. We do have the largest number in Wales. I'm aware of that. Yes. Okay, thank you very much. So no more questions are asked to note the report. Thank you. So I'll move us on to 4.2, Corporate Risk Register. Do you want Joe to take this, or?
Oh, happy for Joe to take
it.
Go. It's ready to go.
Thank you, Chair. So, just to rest the board, since the report was presented to the board in January 2024, even, the risks have been reviewed by all of the committees, and also they've been reviewed by the exec team. And as we discussed earlier with the quality and safety report, where there are areas of concern, for example with the septic unit, that will be coming back to the next quality and safety committee to discuss that risk in more detail. So there's currently we've got 23 risks on the corporate risk register, 6 of which are new this time, 2 have been de-escalated, and 1 has been increased, a reduction for 3, and 13 are still at the same level as when they were last presented to board. So that detail is appended in the SFAR chair for that. We have got 2 risks which we do need to know are in the in-committee domain because of the sensitivities of those risks relating to cyber and physical security. And there are also 5 risks that the exec risk group have asked to be reviewed before they go into the next round of committees for reviewing in relation to security, delivery of the annual plan, the 2 risks relating to well-being of our workforce, and as I've already mentioned, the aseptic unit. So I wasn't going to go through any more detail of the paper, Chair, because it has been through the committees, but just happy to take any questions or for the risk owners to respond to any questions from members as well, Chair.
Okay. Before I open it up, can I just check what it says about Chair's action on 1812 and 1810? Is that February 2024 date correct, or should it be 20?
It wasn't
23.
February, February 23, Chair.
Yes,
yeah.
I was just worried I was losing my short-term memory and that I couldn't remember doing it. It's because I didn't. So that's a slight relief. Thank you. So if we can just correct those 2 dates. Yeah. Thank you. Any questions on the corporate risk? Maynard.
Thank you, Chair. Risk 1531 on page 11 of the report is the risk that has actually increased. Concerns the consultant on core rota in Withybush and Grangwili. It says that the recommended solution to the rota fragilities on both sites is to consider combining the 2 rotas. And I'm just wondering what's happening on that at the moment, and how are we managing that process?
Andrew, do you want to take that, please?
Yeah, I will do. Mark may want to come in as well, but I think that concerns as it says, the general surgery on core rota. It's a key work stream of the clinical service plan, which I think we've got an update on coming up. But it's through that clinical service plan work that we're working through what the sustainable model for general surgery emergencies across the health board will look like. And obviously, one of the options that's being discussed is consolidating that rota onto one of the sites.
Thank you. Mark, do you want to say any more?
I think Andrew has answered it really. So emergency general surgery is part of the clinical services plan, and options have been, I'll give you a summary in a few minutes, but options have been developed And as you know, we're hoping to come to board in September with those options. At the moment, the risk has been mitigated by locum usage.
Okay, thank you. Eleanor.
Thank you, Caderia. It's a comment more than a question. The two amber risks relating to staff well-being, I'd simply like to say, as a board member, I have every bit as much concern for the well-being of the people in our service delivering the operation as around the executive team. The risk to the corporate plan may be different, but I think it's really important that we have a duty of care to everyone and share the concern for their well-being in that way.
Yes, Chair, and that particular risk was reviewed in the People Committee, and also that's one that the exec team have asked to be reviewed as well. So there'll be, sorry, Lisa, it's Lisa's risk. Sorry, Lisa.
Yeah. Lisa, do you want to add?
Yeah, just to add as well, that management risk isn't the executive team. This is about all managers within the organisation. But yes, we discussed it in People Committee and are reviewing it. Thank you.
Okay. Thank you very much. No more questions?
Sorry, Chair, just on your point of clarity on Chair's action, sorry, because you've been on that bit. It's Chair's action by the Chief Exec as the Chair of the Exec Risk Group that was taken.
Sorry.
And then it was ratified by the group because we had to take the decision. So we need to think about the wording because it's not Chair's actions as in Chair's actions. So sorry about that.
Okay, so it wasn't right. Okay, well,
so you weren't right.
It's me, not you.
It was you, not me, which is why I don't remember. Okay, thank you for clarifying. So the recommendation is there. We've commented on that. We're happy to accept. Thank you. So we're moving on to 4.3, clinical service plan, which I understand, Mark, you're taking.
Yes, thank you, Chair. So I'd like to start off by just reminding the board back to March when an issues paper was presented to the board, and that was essentially conclusion of phase 1 of the work. We're now into phase 2, and I'm really pleased to say that's progressing very well. And phase 2, as a summary, is essentially the options development stage for, if you recall, the 9 areas that the board identified that we wish to focus on. We are progressing well, and we're on track at the moment to present those options to board in September of this year. We have made some governance arrangements. I've taken over chair of the Clinical Services Plan Steering Group from Lee, and that's in line with our new governance structure that I think you're all aware of. We're up to, at the moment, so Sprint 1, as we're calling it, which is one of the phases of, one of the parts of phase 2, we've developed a long list of options, and the output of that has been reviewed and presented at a number of check and challenge sessions. Sprint 2 occurred at the end of last week. And that, again, had excellent attendance from our clinical and non-clinical staff and our stakeholders. And there's continuing ongoing good debate. So I think it's clear that everyone is very much engaged in this process. After refinement of the options, the group scored the options that were presented. And 4 out of 5 options were deemed to meet the hurdle criteria that are described in the paper, and I think we've all taken you through before. Since then, the service responses that we got will need testing, and the clinical reference group, which I currently still chair, has been asked to consider the output of those sessions. Of those discussions, and then that will then feed into the next session, which is step 7. Sorry to get a bit technical, which is at the end of June. I will be testing you all. So that next step, when we look at those 4 options, we'll undertake a SWOT analysis, and just for maybe our public watching, that's strength, weaknesses, opportunities, and threats. And once we've done that, that will then move into the next stage, which is when we'll begin to score those options. We are seeking some board approval, if we can, please, in advance of phase 3. Phase 3 will be the stage that will occur after September, We are looking support to begin a procurement process so that we can secure some independent support and procurement. The budget exists and is in the Director of Planner's budget, so don't have to be concerned about that. But we do need some support if that's the case. So, in summary, the clinical services plan progress is really good. And on behalf of the executive team, I'd like to thank all of the staff and our stakeholders and FLICE patient representatives who've attended all the sessions. Everybody still has their day jobs, and our expectations, as we've heard, are still very high. But everyone is working really hard, and as I've said, we're really pleased with the progress to date.
Great, thank you, Mark. It's very helpful. It's really interesting, a really good paper, and I can't remember all the steps, so yeah, I'll have to learn them. Thank you for that. It's a very comprehensive paper. Any questions of Mark? No? Oh, okay. Oh, Owenna, sorry.
Sorry, just to note that whilst we do have a communications and engagement plan to back up the clinical services plan, as we're about to, well, we are going into a quiet period ahead of the elections, we are pausing any communication around that, so just in terms of transparency as to why we're halting proactive communication on that.
Yeah, and just to emphasise for those listening, that is a requirement which happens during any election period, so it's not something that is special in that way, and it will apply to all organisations while we go through that the election period. Thank you. Rodri.
Just one point. The service tool says that independent consultation engagement support has an estimated value of 107,000. Can you just clarify, it's an estimated value, kind of when will you be more firm regarding the value of that, or kind of the...
I think that depends on the outcome of what we decide as a board to do. So we can't really make a commitment what we're going to need to do at the next stage until we know what we need to do. But I think that's just, maybe you can help me, maybe that's just best based on what we previously spent on for example, the paediatric process.
Yes, yes, Chair. So I think the intention at this point in time is to go out for a call-off contract so that we've got someone on the books that's been tendered and procured appropriately. Then we can scope up the precise work details that we would want to put in there. I think it's a surprisingly kind of precise number for something that at this point in time is relatively unknown and is representative, as Mark said, of the scale of expenditure we've incurred in the past.
It's just that figure, it looked quite precise, but I don't like open-ended figures. I don't like estimates, so that was only...
And Chair, what the Director of Planning has also said is part of the paper that they'll come back in September will include that. So this is just as the Director of Finance said, if we wait till September, we would then have to go to procurement, which would then slow down the process. This is seeking the board's approval to do that piece up front because it's over 25,000, so any consultation over that level has to be approved by the board. And then as part of the September paper, that detail will be in there, knowing then, as the medical director said, what exactly we may need to engage upon at that point.
Thank you.
Okay. Right. So if there are no questions, then the recommendation is there to note, but the approval is to approve the start of the process for procurement, not to agree any figure. That will be coming back to the September board. Okay, thank you. Thank you very much. So we'll move on now to the primary care community strategy update. Jill.
Yes, thank you. And as Mark already alluded to, the March paper that we saw out to the board in terms of the clinical services plan did include a significant chapter. Sorry. Thank you. So the March paper that we saw at board did include a significant chapter on the primary and community strategy, developing the issues paper, and this paper basically sets out the start of the development of phase 2, which again will be developed in line with the agreed planning framework. So just in terms of what we've done over the past 3 months, we've developed a proposed governance structure which includes the 4 working groups that you can see set out in the paper, confirmed terms of reference and membership. We have had 1 meeting of the strategy group, and we have a further meeting next week. And we've confirmed and strengthened the scope of community, and we recognised from the discussions at the previous board meeting that we need to go back and review the phase 1 for the aspects that relate to our community services. We've set out a plan for communication and engagement which will be developed in partnership with our communication team. And there's also been further engagement with the exec team and wider stakeholders, including Welsh Government. And it's helpful to note that there is work starting at a national level as well to review the primary care model for Wales, and that's commencing in June. So we will be working with Welsh Government and all of the stakeholders as part of that process, which will fit with our work, and hopefully we will be able to learn from that. I think what we're increasingly recognising, certainly through the discussions with the executive team, is the extent and the scope of this piece of work, which is quite significant. And I think it's also important that I reflect that we're increasingly recognising the interrelationship between the problem we're trying to address, which I think is our urgent and emergency care issue, and the role that hopefully for the future primary and community services are going to play in terms of helping to address that. But what we don't want to just jump to is the solution. And I think when you look at other strategies that may be available online, they deal a lot with the what, but not the how. And I think there's going to be the work over the next few months to develop the options with firstly our workforce, to think about what we want to test further, and then in the latter part of the year to talk to our population once we have a better idea in terms of what that new model might look like that we want to discuss with our community. So this paper, as I said, is before you today. It sets out the range of work that we need to do. And as a consequence of the extent of that work, we are proposing an extension to the original deadline of bringing a paper back in our May board rather than our March board. And I think that really simply reflects the scale of what we need to do, and working backwards then the committees and internal arrangements that we would want to go through to satisfy the governance requirements, and to make sure that we do proper justice really to the work that we need to do. So it is before you today. I would want to be expecting to tap into the resource that Mark's already referred to through our planning team. But I know as we also work up phase 2, we're going to need to make sure that we have got engagement from the relevant corporate teams and our planning team in terms of helping to take this forward.
Thank you. Thank you, Jill. Eleanor.
Thank you, Jill. A comprehensive paper. And can you pull the microphone? Again. Sorry. Thank you. Thank you very much, Jill, for the paper. It's comprehensive in what you've outlined. I've got a few questions around it, and it's a really important building block looking towards the social model of care and to deliver that vision of the healthier mid-Wales that we have before, all of that. The questions I have are partly around pace and time and how we work together. So I think for me, one is, are we letting the excellent be the enemy of the good here in not delivering it a bit sooner? 2, I fully recognise the importance of engagement with the public and the staff. But again, do we need to take quite so long as this to do it? I suppose the third bit of it, is this the only or the best way to engage people? I wouldn't want waiting for the primary care plan to get in the way of people working more closely together more quickly, because the patient pathway is really important.
I think those are some really important points that you've raised there, and we certainly wouldn't want to delay on any of this. So we won't be waiting for the conclusion of all of the work at a national level, or even the things that we know already. And one of the things we've really recognised is that in all of the engagement that we do and in the consultations that we have undertaken, even in terms of land, we know the issues that people have concerns about in terms of access to services within their primary care setting. The work that we do need to do is both working with our communities to establish a resilient model within our community that allows us to optimise those services that we do provide and contract for to work most effectively. So there's an important point in terms of how we do those pieces of work. But we've got a strategy meeting next week, so I will take back your concerns around pace, and I will ask that as we develop and establish the work for those work groups, whether or not we can bring forward that timescale. So we will be providing regular reports into the SDOD committee. So it may be that in our next update to that committee, and then also for the next board report, we're able to review that position. But I'll obviously be talking to you outside of that as well. So we're having regular conversations within the exec team as well. For me, this is such an important piece of work, and I really want to make it live. That it's not just a process we're going through, but it's something that we all own and understand, because it really needs to be the solution for some of the challenges we face for the future. So thank you for those questions, and I will make sure we address those through our strategy meetings.
Okay, thank you. Any other point? Ewan, then
a minor point of clarification, just on the plan. I noticed you've got some decision to be made by the board in November. So I'm assuming SDODC will see them in the October meeting?
Yes.
Yeah, it wasn't on the plan, just wanted to make sure that was there.
That was also part of the planning we did, working back from the May board next year, to make sure that we've actually got products available to get us to the May board. We're actually talking about sort of having to have them ready by about January, February time. So, you know, there's a lot of work to do, but of course those points will be reflected. But thank you for checking.
Yeah, I hate volunteering for work, but...
Ewan.
Okay. No, thanks, Jill, for this paper. I think it's great to see in terms of the structure to support in terms of that community provision. Just in terms of when you go into the phase where you actually go and talk to the communities, the public as well, just to kind of perhaps highlight there may be perhaps emerging networks which perhaps aren't articulated in this report, but certainly I'd be happy to provide and kind of be part of the solution, because there was one example, and again, third sector partners coming together back in end of February, early March, and within just Carmarthenshire alone, we had 45 organisations in one room actually articulating all the support services that they provide within the community, and we kind of captured all of that, and we've got another of those Carmarthenshire events coming up in June, down in the Furnace Theatre in Llanelli, and again where they're coming together to actually articulate what they're all doing, but then to share that to make sure that the resources aren't duplicated. And I think, again, happy to provide that as a further solution to this work, to enable the team and the work you're doing to have that real access into the community structure, to enable this to then really kind of articulate what we need to do.
Thank you for that opportunity. I'd really welcome that engagement, and also just to say our counties are also going out to communities in various engagement events as well, so making sure that we supplement all of this work with that. And I think hopefully as a board we'll see this develop. It really needs to get past feeling that we're in a very process delivered position, and to get out and feel that we're actually delivering and engaging with our staff and our communities.
Thank you, Jill. Did you want to say something?
Yeah, maybe just come in. So I suppose, this feels like a really important piece of work. We did talk earlier about how we sought to refresh our strategy when we were talking about the Nuffield report. And so I think, you know, that this is a key part of that, I would say. I think, you know, the discussion's been really helpful. I think the point about, is there a way of reducing the timeline? I think we do, you know, I know the team have been looking at it. It's a challenge to do that. There's all sorts of reasons why the timeline has been set as it is, but I think quite right, we need to have that challenge around perfection being the enemy of the good. I think the other thing we must do is to seek opportunities throughout the year, if that is the timeline, to make progress. So to seek opportunities from that national work around primary care. I think also we need to make sure that it isn't just primary care, it really does need to be the full scope of services that are outlined in the paper, as you're suggesting there, Yuan. So some good challenge. I'm glad we're profiling it here. We are, as we said earlier, really relying on progress in this area. The last thing to say is we do already invest quite a lot of money in community services and primary care services. So we do need to just think about our current investment and the way we work in partnership and seek those opportunities through the year, given some of the plans we have through the year are going to rely on that.
Thank you. I think Andrew wanted to come in, which I missed. It's all right.
Sorry.
I realise not being in the room is not ideal, and I know Alina's just criticised my conducting skills with my pen waving. So
that's what I thought you were doing.
For that. So apologies for that. I obviously, well, I'm not very good at tunes, then, am I? Really, I think was the message I got from Alina. So no, I just wanted. It was just some support for Jill and what she was saying. I think we had to. I just want to say we had a really good conversation this week. I think Jill, myself, Sharon, Mark, Ardiana and James, so the clinical executives around the primary care and community strategy. And I think it's also important that we recognise, in fairness, that we're not waiting for the strategy for some of this, or a document describe the strategy for some of this to happen. When we get into the detail of what's in the 6 goals plan, at the heart of that are the issues around how do we develop our community, enhanced community care model, how do we how we develop hospital at home, how do we make sure we've got a resilient urgent primary care model, how are we streaming, how are we avoiding admissions. This is all in this space. So I think it's just, I just wanted to say that, because I think there's an awful lot going on already that if we're not careful, we'll get on and do, and we won't link it back to a really important objective we've got and miss that alignment. I know Jill's aware of that because we've had that discussion this week, but it was more just for the board, just to say I think this isn't we're not waiting for this to be able to start doing some of that work which we agreed in our original strategy several years ago.
Okay, thank you, Andrew. I think the other thing I would say, we don't spend as much in community and primary care as we do in secondary care. I think Hugh will back me up on that. Yes, thank you.
Very true.
There's a lot of initiatives funded, I know, but...
In fact, just to add, actually, the issue has been actually that there's been differential spend increasing in hospital services, which links back to all of our conversation earlier.
Okay, thank you. Right, so the recommendation is there on page 8, which is to approve the framework. We intend to do that and note the date. The only thing I would say, I know this is of particular interest with our new chair, so obviously he will be, and perfectly able to change that when he comes, if there are further discussions as to way that might be speeded up. And I know, Jill, you already said you've got your meeting next week, so I think that date will keep under review, but it does need to be done in a proper way, bearing in mind what Ellen has said. So I wish you luck with this, and I will watch it with interest because of my previous hat. So thank you, Jill, and thank you for the paper.
And thank you for your support for our service. Thank you.
Thank you. Right, so Andrew, over to you for the Regional Pathology Network.
Thank you, Chair. So I'm conscious there's quite a lot of detail in the paper and a lot of information, and also in the appendix. I wasn't going to, please, I'm not going to talk too much around or go through that. There were just, I guess, some points I wanted to make and remind us of before we maybe take any questions or have a discussion and take a view on the recommendation. So in November 2022, we agreed as a board, as did Swansea Bay, that we would start to develop an operational delivery network to support a single pathology service across South West Wales. I think it's worth recognising that a network solution is commonplace for pathology, is commonplace across the UK, but it would be the first network pathology service in Wales if we were able to progress this over the next 12 months and beyond. Pathology services themselves are a really key and core component to a lot of our health service delivery, and within our risk register there are risks around, for example, the fragility of our histopathology service and the impact that can have on some of our cancer pathways and our ability to have appropriate representation at our cancer MDTs, where we are planning and deciding on treatment routes. And the clinicians believe very strongly that the best route to resolving that is to develop this network approach, working across the two health boards. They think that's the best route for them to be able to develop a workforce plan that's attractive, resilient, but also it's also the scale, they also believe, will help them put them in a place whereby they can maximise the benefits of some of the digital and technological developments that we're seeing in this space at the moment. So I think there's some real positive aspects of this. I was asked to chair a task and finish group to develop the principle of a joint management structure, which is where the governance framework of the ODN emerged from as a means of doing that. I think originally that was being driven by the capital programme that was also running, that had been running for some time in the background around the development of a new cellular pathology hub and centralised cellular pathology hub in Morriston, and redevelopment and refurbishment of a number of labs across the patch, and including within our health board. And whilst that work has slowed, I believe strongly, as do the services, that actually, even without the capital development, there are benefits to still progressing with the single service model across the region for the reasons I've explained in terms of workforce fragility in particular, and the attractiveness that a network could provide given they're in place across the rest of the UK. We are already seeing some benefits in specific aspects of the pathology service currently, where we have developed a regional model. So members of the board hopefully are aware, but because we've referenced in other papers, but just to be specific, we do have a joint management arrangement for mortuary services across South West Wales, and I think we are seeing the benefits of the calibre of people we've been able to attract into that joint management role, and how that's really driving and changing how and addressing some of the challenges we've had locally with our mortuary service and its mortuary services and its provision. So it's important to stress that what this paper is setting out is is for us to agree what's described as the transitional MOU. So this will enable us, or an MOU to set up a transitional board, which will enable us to do the detailed work, appoint to the senior roles to lead that work, that enables us to set up a formal network intended to be ready for next sort of April, May 2025. So I don't think there's anything else for me to say. I just wanted to make those few points, Chair, before we had a discussion.
No, that's fine. Thank you very much, Andrew. So, any questions on this paper? Maynard.
Thank you, Chair. Andrew, I know and understand the value of the network approach, even without the capital. But one is a general point about capital schemes in particular that's come up twice today already, in that from the SOC stage to the OBC, there often seems to be a delay that increases our costs significantly, but then it causes us to have to do more work and therefore delays projects. Well, that's just me making a general point. I'm just wondering if there's anything we can do to actually shorten that gap although I know some of it's in the gift of the Welsh Government. So that's one point. Second thing was, again related to the capital, that Swansea Bay ranked the pathology capital scheme as 8th amongst their priorities. I'm just wondering, given the number and scale of some of the other priorities, how likely they are to get that money. And the final point, one of the things not mentioned in here is the financial implications of setting up the network in terms of whether there's a financial benefit to the health board or whether we're going to actually increase costs. I'm hoping it will be the first, but just for clarification.
Thank you. Andrew?
You're on mute, Andrew.
I would probably be, sorry, I think I'm off mute now, am I?
Yeah.
You're fine now.
Yeah, sorry. Yeah, if I take the latter point, because I'd probably look to Lee to help me with the capital question if he was here. But on the latter point, I think obviously a part of the work we need to do in detail through the course of the next 12 months is be really clear about what our intended service specification is and our budget for this service across the region. There'll be probably some challenging conversations in that about various levels of budget versus spend and whether what we're both putting in reflects, is where we feel we need it to be. But that will be part of the work of the transitional board to work through over the next 12 months. I believe, like you, Maynard, that I think once we've got it up and running, there will be opportunities that come from the economy of scale you get in terms of, particularly around procurement. There's an awful lot of expensive equipment and procurement issues that I think being able to do that on across a bigger region, a bigger footprint, and on a bigger scale will help. And I know we've been trying to make sure that as we're working through managed service contracts at the moment that we both have, that we're trying to, the services are trying to see how far they can align those ready for any future network arrangement being in place, because that would obviously give a benefit. But I would hope it will give us it will make us a better value and more efficient service by having the regional model. I think your concerns around the capital issues are really valid, and I guess being aware of the sum of money involved, I think that at this point in time there'll be a challenge for Welsh Government to find the money to enable that scheme to progress, which is why we did have, as a Tusk and Finish group, a detailed conversation at one point a couple of months ago or at the turn of the year, which is, so if we don't have the capital, is this still worth doing? And the resounding view from the senior clinicians and service managers, senior service managers in the room, was that it absolutely was, because we've still got all of the other service and workforce fragility risks, even if we don't have that we could address, even if we don't have the capital, the full capital solution.
Okay. Thank you, Andrew. Rodri?
Well, just one question on perhaps the MOU itself. Not that I'm going too much in detail, but can I see that the Swansea Bay, that's the lead for every one of those activities? And if you look down then, when it comes to, obviously the lead is the health board with principal responsibility, but then as an assure, they will make the final decision on any activity then, will they? Because it says in the show that they provide input to the lead before they take a final decision, just to get clarity on that. So
So the MOU is for both organisations and has been already approved through Swansea's board with some caveats. So reporting will be worked. Obviously, this is a transitional MOU for this year. There'll be a formal MOU for next year, which all that will be worked through. But because it would be hosted by Swansea, in essence, that's why it would go through that reporting line. But the MOU would detail how we feedback all that into Health as well. I don't know if Andrew wants to add anything.
It's just that last part, the lead, before they take a final decision. I just thought if it's a joint, I'm just wondering, kind of making that final decision.
Yeah, well, if it's eventually hosted by Swansea, that's why you'd have to do it through that route in governance terms, because it'd be hosted by Swansea on behalf of both organisations. Do you want to add anything, Andrew?
Well, I only the point that I mean, obviously that's the governance route, but the principle is that there is effectively a joint committee that's commissioning the service and holding the network, the jointly appointed network manager and network clinical directors to account for delivery of the service.
Andrew, can I just raise one thing? As you know, there's been quite a lot of concern from some of the staff groups in our laboratories and a little bit of misinformation around the impact of this. So can I seek assurance that that engagement process will be ongoing, because there does appear to have been quite big gaps between the staff actually having something last, I think it was October, and sort of more up to date. So just that will be ongoing and more frequent.
Yeah, no, there's definitely the intention to have a more formal program of engagement with staff across both organisations. I'm also very conscious that, as you say, some of that concern and noise that we're hearing is also due to some misinformation around what is and isn't included. And I know I've had a conversation with the chief executive around perhaps a visit to a couple of the sites that are particularly concerned, just to provide some reassurance as well. And I was also with Delith on a patient safety walkabout last week, and as we were walking around, I stressed to the blood sciences manager where a lot of the concern is arising from, which is a service that doesn't get centralised even with the capital solution, that we needed to make sure we were very clear and on that message and repetitive around it, so that it couldn't get misinterpreted.
Yeah. That's great. Thank you very much. Okay, so...
Sorry, Chair, there's just a one governance point, because it's already been through Swansea's board. So just for the board, Chair, this is a transitional MOU, which is obviously given the time to discuss today, staffing, operation and governance issues, but you will have a more detailed MOU before this becomes operational, that both organisations will have to sign off at that point as sovereign bodies. But just to flag, they're on clause 12.6, prior to it going to Swansea's board, there was a further discussion between both organisations. So that clause only relates to new staff joining the ODN that will be appointed by Swansea Bay. Right. So how that staff will remain subject to our policies until the transfers and even after that. So I think it's just a really important point to clarify, because some of our staff were really concerned about that. And obviously there'll be the TUPE and the protections that comes with that. And clause 23.2 will be reformatted. And I think Andrew mentioned a transition board. It won't be a board, it will be some sort of vehicle. So sorry, Andrew, just because so we don't avoid the confusion of it going to a board, because we only have 2 sovereign boards. Okay. And just to thank, if possible, Chair, Jean-Marie James for the work she's done on this on behalf of both organisations. Has been an inordinate amount of work she's done behind the scenes to get us to this point. So I'd just like to formally thank her on behalf of Andrew and myself, if that's okay, Chair.
Yes, of course, and certainly reiterate that. And I think the issue about the employment and any transfer is the one that there was some misinformation about, and people assuming they were transferring over to Swansea Bay almost immediately. Yeah, Michael.
Sorry, can I just ask a question on the governance point? I might be being dull. So, if this was all finally all set up and everything, Joe, and I'm just thinking as a lawyer who has traditionally reviewed public bodies, if they did something, if this organisation does something, and I'm a member of the public, and I want to challenge it, who do I challenge? Do I challenge Swansea, or do I challenge? Who do I challenge? Who's kind of got the legal entity? Because it's not got a legal entity, has it?
So at this point in time, you would whoever the host is. So we'll be continuing as we are for the next 12 months. Once we go to a formal MOU and a hosted service, then it would be through Swansea Bay. But we're working through that with the lawyers over the next 12 months. Because if it is, that's the way the plan would be. Yeah. So it would be that, and then people would transfer over as well. So we just need to work that through, but I can go through it with you offline.
But I say that is enshrining the ultimate decision is Swansea. You see, then it's kind of enshrining. We've got to be careful not to lose a bit of control over it. Yeah, which is Rodri's point. Exactly Rodri's point. Yeah. So sorry to kind of piggyback on you, Roger. I think that's a really good point. Yeah.
And that's why the transitional year is really important, to agree what's in and what's not in. So the next 12 months, that's what Andrew's chairing and leading, which will then come back to both organisations to make a decision or not as to how that progresses.
Okay, thank you very much. So the recommendations are on page 8. There's 2 there to note, but we're asked to support the adoption of the transitional memorandum of understanding to enable it to take the next steps. But there will be further iterations of this, and something will come back
But this time
next year.
A bit earlier,
Okay, we're content to do that. Thank you very much. So I'll move us on now, because I do want to do this last report before we take a break for lunch. Peter's been waiting very patiently, so he's here for moving us forward on the Sexual Assault Referral Centre. I think, Peter, if I may, before we start, I think none of us are very content with the timescale that this has taken. 2013 was when this first came up, and I know there are all sorts of reasons for that, and I know it's not a situation you would prefer us to be in, but we are at the next stage and hopefully finally seeing this come to fruition. So anything you'd like to highlight?
Thank you, Chair. I don't have any intention on going through the 17 appendices, and I do apologise for those. It's a necessary evil, I'm afraid, in terms of the process. Yes, this process was started in 2013 via Welsh Government review, and as some of you may recall, it came to this board some time ago in terms of the approval to go on a regional basis, which we got approval for across all health boards in Wales. I was asked to step in 2022 to gain pace and delivery on this because it was stalling somewhat. We have explored a number of options with regard to a hub within the West Wales area, and we've arrived at, because of partners' preferences and the regional approach, a solution which is involving the Carnarvon Rydal building in Aberystwyth in conjunction with our local authority colleagues from Ceredigion County Council to deliver this scheme within the building as a sort of leased arrangement and refurbishment of the building. This is the 3rd time that this has now been to board in terms of its scrutiny process, and the cost has obviously increased, which we've seen on a number of projects recently. This is now a project of 3.391 million to deliver. We are confident that that is the cost, which is going in the BJC to Welsh Government, subject to approval today from the board, and is deliverable. All partners are signed up to that across the police, third sector, health, and the SARC collaborative across Wales. So there's no major disagreement between partners on base or the process. This will mean that the centre that is in place in Newtown and the one in Carmarthen will be created into a hub into Aberystwyth. However, the ongoing counselling and support services will still be available locally to people that require them following the incident that happens. The real deadline, the real issue for us on this one is the ISO accreditation deadline, which is now November 2025. It has to be hit. Evidence in court won't be suitable if we can't get to that date, so this is a really tight delivery in terms of the timescales that we've got to have. That, I think, covers it. I'm happy to take any questions, Chair, if there's any.
Thank you, Peter. And I always get the feeling when you take something on, we do move it forward. So thank you for that. Any questions for Peter on this? Anna?
Yeah, thanks, Chair, and thanks, Peter. And Chair, thank you for acknowledging the length of time that this has taken to progress. I think it would not, I certainly don't feel it would be too strong a word to say that it is shameful that we are in this position. And the human costs, which this paper doesn't set out and was not intended to, admittedly, but the human cost will have been very significant over that 11-year period, and still we are not in a position to resolve that yet. And I think we need to recognise that that is likely disproportionately to have affected women in our population. And it would be helpful, Peter, to know if an equality impact assessment has been undertaken to evidence that that is the case. So I suppose my question is, where does the accountability lie now for a speedy resolution to this situation, and what role does this board have in ensuring that accountability is upheld?
Okay, just to be clear on the role of Hywel Dda in this, the role of Hywel Dda is to deliver a ISO accreditation standard building as a part of the process. That's our role. There is a bigger role, obviously, for the national team to deliver the infrastructure in terms of the staffing and the third sector involvement, etc. But our role in this is for us to deliver the building, which potentially subject to approval today and subject to Welsh Government approval by the end of the summer, means that we'll do that by 2025.
Okay, thank you. I should just add that normally we would take these at this stage through SDOG, but in agreement with the chair of SDOG and discussion with our Director of Strategy and Planning, it's been
Action yesterday.
comfortable, they've taken chair's action to bring it straight to the board, so we don't delay any more through our processes. So thank you, Maynard, for doing that. So we are asked to approve. Oh, sorry.
I just want to confirm something. So there is an impact on our revenue costs. Sorry, there is an impact on our revenue costs. Is there not in approving this business case in future years? I think there is, because I think it's in on page 757. I think it sets out our revenue cost impact. So I think as a board we need to acknowledge that given our current year's financial situation.
Yeah, it's a fairly nominal revenue cost that is being managed within the Women's and Children Directorate.
Yeah, it's within the existing budget, which is used in this element anyway, within the Women and Children's Directorate, and is in their budget setting process for that 11,500.
No, it reads differently from what I can see. So there's a appendix table 16 which sets out the different cost elements: the lease costs, the premises costs, the IT costs, equipment costs.
Oh yeah, but the net pressure is only an extra 11,000, so that's being managed within the directorate. I'll happily pick it up offline with you.
Yeah, I just think we need to just minute that we're very, very clear that the increased cost on this paper is offset by the existing budgets. I think that's important.
Yeah, important point. Thank you. Thank you, Winston. Okay, so we're asked to approve the business case for submission to Welsh Government. We're happy to do that. Yes, thank you. Peter, thank you very much. Thank you for sitting through the board and attending for that item. And you're very welcome to stay for the rest of the meeting. But you're also able to return to Ceredigion if you so wish. So thank you, everybody. It's now 1:15, so we are going to take a break for lunch of around about half an hour. So if we can be back ready to start just before 10 to 2. Thank you. Okay, welcome back, Prynhawn Dar. Welcome back to the rest of the public board meeting of Hywel. So we are now up to section 4.8. So I'm going to move straight on, and that is our paper on funding nursing care, and I'll turn to Jill.
Thank you, Chair. Board members will be very familiar with the context and history to this paper, so I won't go through the detail. But it is important that, as the statutory body, that the board has the opportunity to consider the recommendation that has been worked through in line with the inflationary uplift mechanism, which is a mechanism and approach which has previously been agreed by boards in order to calculate the funded nursing care rate for this financial year. So this has been worked up by the peer group in association with the Directors of Finance, and the recommendation went to Chief Executives. It has also been considered as a recommendation by our own executive team. So it comes to this health board today. It has also gone to, or is going to, other health boards across Wales, and you can see that the recommendation on an interim FNC rate is recommended at 3%. And the reason we're coming to you with an interim rate is that historically we haven't made the payment until we have had the calculation on the pay award, which underpins part of the component of this calculation, and that comes at quite a late point in the year. So for the last 2 years, Welsh Government has encouraged health boards to make an interim rate on the basis that we get a settlement or some cash flow out to our care homes as quickly as possible. And that does mean that we then would potentially need to review that rate as and when we're aware of the pay award, which, as I say, informs part of the calculation, which is based on registered nurse time and continence products. So there is a risk in terms of moving ahead with an interim rate, in that the rate or the pay award may end up at a settlement that is lower than the recommendation that we're including here. And if that were the case, then we would not be able to recover the position. We would continue to make the payment for the rest of the year at the 3% level that's recommended today. If it does increase, there would be an expectation then that boards adjust that to pay the additional uplift that we would need to make. And you can see that with the calculation that's set here, the overall figure for health boards to pay would be calculated at about £213 per person per week. That reflects the 9 hours or so of registered nursing time. That's a contribution to the overall care that somebody receiving funded nursing care would make. And the risk for us in terms of this is in the order of around an additional, I think, £96,000 for this financial year. So I'm bringing it to the Health Board today for as a recommendation for agreement on an interim basis until such time as we're aware of the final pay award that may, as I say, mean that we would need to adjust further this rate.
Thank you very much, Jill. It's very clear. Any questions for Jill? No? Okay, thank you very much. So recommendation is there. Are we comfortable to approve the interim rate? Thank you.
Thank you.
Thank you, Jill. So we now move on to item 4.9, and I would like to welcome to the board two colleagues, Bethan Lewis and Hannah Thomas. Welcome, and they're here to help with any questions on the next item. So, Ardiana, you're going to start.
Thank you, Chair. So the item is the paper on our immunisation equity strategic plan. Welsh Government has asked all health boards to develop strategic plans to improve equity in uptake of immunisation programmes, and Hannah, the Specialty Registrar, has worked on developing with colleagues that strategic plan. Hannah is going to just highlight a couple of key points from the paper and take questions, and Bethan will support. Thank you.
Thank you. No, sorry, you have to have a microphone.
Thank you. Can you hear me now? Now? Okay.
Yes, thank you. So this vaccine equity strategy or immunisation equity strategy brings together the most recent data we've got on immunisations, which were brought to board in January. Just to pick up some of those key points there, some of the areas where we are looking to improve the equitable offer that we've got from the Health Board. In terms of MMR, Hywel Dda achieved slightly below the All Wales target in terms of the first MMR vaccine. But then when we look at the second MMR vaccine, every one of the GP clusters in Hywel Dda fell short of the 95% target. So just one example of where we see a real difference between our most deprived and our least deprived areas. So we really need to look at targeted work to understand some of the barriers that we've got in terms of people accessing vaccines and the uptake of vaccines. We know that those clusters of individuals and communities, if we leave those unvaccinated, there is that potential for outbreaks, as we're seeing in other parts of the UK in terms of measles at the moment. So the immunisation strategy is a 3-year strategic plan. And the main approach that we're looking at is firstly looking at the data, making sure that we understand the provision of vaccines across Hywel Dda and really understanding any areas of inequity that we've got in the Health Board. From there, the next phase of our approach is around continuing to engage with communities so that we understand any of those barriers to vaccine uptake. And then finally, our delivery of an approach which considers how we address inequity, how we address people getting the right information in order to make informed decisions about being immunised. So our recommendation is that the board approves the strategy. We will be looking to progress our actions with the Immunisation Oversight Group. Welcome any questions.
Thank you very much. Thank you, Hannah. And just to clarify, because I think the Welsh Government introduced the immunisation equity strategy, so we've been asked to develop a plan to implement that strategy, which is what we have here today. Okay. So, any questions, Chantal?
Thank you for this. I'm just wondering, in particular in terms of ethnic minorities, because they tend to be the group that either is a little bit more scared about vaccination or perhaps not quite understand the system as to how they can access the vaccination. Are there any specific plans that we are likely to put into place in order to target that particular group?
Yeah, so it's something that we've picked up in the strategy. We've looked at what the evidence says around the best ways to engage with those communities, and they are a key area that we'll address as part of the plan. Beth, I don't know if there's...
We work very closely with the Community Development Outreach team, and we've reached some of the communities already across Hywel Dda. It'd be important around our translation materials as well, and how we can ensure that we have trusted voices in the communities and engage on that level also.
So you'll be using the users themselves, those who you've accessed in order to do that. Okay, that's great.
Thank you. Ewan?
Yeah, picking up really on the point just made, really, in terms of you highlight the BME kind of cluster of population, but in West Wales, I mean, that's probably less than 5% of the overall population. You talked about the missed targets that we've had already. So what communities of place or communities of interest within West Wales would you be targeting in addition as well? Are there specific areas in terms of the Welsh Index of Multiple Deprivation, or are you looking at other kind of demographics as well?
Yeah, so there's a few areas we've picked up, certainly in terms of the index of multiple deprivation. That's one area in particular. We need to make sure that we've got an equitable provision for our Welsh speakers, that everything that we provide is in both of those languages, but also thinking about our migrant communities, especially people who might come from countries where they've got lower rates of vaccination. So again, we've highlighted those particular groups across the plan, and part of the next steps is really trying to understand that data so we really understand where those pockets of lower uptake are. But certainly we need to consider a whole range of different groups.
Just one more perhaps as well. In terms of rurality, because as we're seeing in terms of accessibility to services as well, how will you support those individuals who are really in kind of deep rural areas to actually come forward and, you know, attend the centres for the vaccinations?
Yeah, absolutely, and that's something else that we've picked up in the plan, the challenges around the rurality and how that. So this is where we have to work in partnership with primary care to understand those communities, to understand some of those barriers. Is it travel? Is it that we're not putting on enough clinics or clinics at convenient times for people? So it's really considering all of the possible ways that we might be disadvantaging people, especially those in rural communities. So yeah, absolutely something that we'll be picking up.
Thank you.
Okay, thank you. Gareth.
Diolch, Cadeirydd. My point was on the rurality aspect, but transport in particular. And I noticed that you've got one example of innovation using the Tenefus bus. Are we having data that the cost of living and the lack of public transport infrastructure is affecting take-up? And have you thought about existing groups as well, like TFV, Ysgol Meithrin, etc., to actually do a kind of group kind of immunisation as well?
Yes, absolutely. Thank you for the question. And I think from a rurality perspective, we have had some feedback, certainly in the autumn campaign with flu and COVID, of people that have struggled, for those where primary care were not able to support the COVID delivery, and it's learning from that. So we have then engaged with local village halls and put a pop-up community so that we can come to the population, and we've worked with some primary care practices and supported alongside them then in those community settings. So definitely people are telling us that it's expensive to travel, and we are very mindful of that then. We have also worked with the nurseries with the children of the 2 to 3 year old flu campaigns. We piloted with nurseries that were attached to schools, but we have reached out to the private nurseries as well to see if we can increase some of the uptake in our 2 to 3 year old influenza campaign.
Brilliant. Diolch.
Eleanor.
Thank you. Accepting that most of the questions are around rurality, the Wales Index of Multiple Deprivation doesn't pick up rurality very well in order to target it. And one of the least immunised areas seems to be Llanelli, which is an urban area. So what are you doing to target the population base in an urban area?
It's very similar methodology to rural also. What we have done is pop up into a local community hall next to a school, so the parents can pop in, utilising the weekend clinics. What we have found over the last few years is not necessarily the want of coming forward to the vaccination, is more that it doesn't fit in with their schedule, or they just can't get there, and it's just trying to understand the barriers for each individual community, because they are very different even across Llanelli as a cluster as well. So it's working with key individuals. We've done quite a lot of work with our travelling community in those areas, because we do have large communities in Llanelli, and we have managed to get supporting that community to uptake, and they were very grateful for us to come along and offer the vaccines in the community alongside them.
Thank you.
Okay, Michael.
Oh, actually, I was just about to ask you about the traveller community, because I do work for travellers communities, and I thought I was going to ask that in the context of partnership, because really partnership with third sector and the like, because you know, I've dealt with say the travelling community, and they, in my experience, there's often a kind of a link into the community, because they quite understandably might be distrustful of solicitors, which I am. You know, I think most people are, but I can see that need for that link in through that kind of trusted link. Now, you talk about partnership in one paragraph, but I assume, again, from what you just said a minute ago, that you're working into that level as well, those kind of trusted link groups, yeah?
Yeah, absolutely. We've got, as a health protection local service, we span with working with Public Health Wales, but also our local authorities, and there are key individuals in the local authorities working with these communities, and our community development outreach team are already in the communities working on all manner of service integration and uptake. So we make sure that we have those vaccination immunisation conversations there.
Thank you, Bethan. Ardiana, do you want to come in?
Yeah, if there are no other questions.
Oh,
Yes,
Chantal.
I just wanted to ask an additional question around GP involvement. Because, you know, when you mention about migrants, new migrants coming in, I know with some of the work that I do in Cardiff, for example, in particular, that community tends to move quite a bit, primarily because the housing situation. So how would we ensure that they have access to immunisation if it's a moving population? And that often happens very quickly. So I know in Cardiff, for example, they can be moved from one hotel to another hotel within weeks or within even days of arriving. So how would we do that? How would we manage that?
I think we work very closely with our local authority teams and primary care teams, and every person or family that moves into the area register with the GP, and they are supported by the resettlement teams that work out of the local authority. So we're aware, so it doesn't matter which route that family or person has arrived, then we understand that route. It may be that they've registered already and the transfer of their documentation, but those questions will be asked around their health, the region they've come from, and also their immunisation status. We've translated lots of documents so that we're able to understand everybody's immunisations record fully, and then ensuring that record transfers with them then, because it's part of their registration documentation with their GP practice.
Thank you. Okay. Thank you. Ardiana, do you want to conclude?
Thank you. Thanks all for questions. I think would not want the presentation, the questions and the answers to maybe give the impression that it will all be solved, and that as of this time next year we will have 95% uptake of all immunisations across all of our communities. As we discussed in January board, the uptake on the key immunisations, and we call them the primary childhood immunisations, has been lower than it should for many, many years. And those attitudes, but also the beliefs, as well as access, and I'll get to access, take time to be redressed. Access is key. And I'll emphasize that because there are loads of other elements, as Hannah talked about. We're trying to understand the actual barriers. We can never understand every single family's barriers and every single little communities, but we know quite enough at UK level and at Wales level what the barriers to immunisations are, and they are mainly access to primary care, which in our health board particularly we do have significant issue. One very key part of evidence that does support that assertion is that we rank very highly amongst all other health boards with regards to school immunisation uptake. We are almost constantly amongst the highest, if not the highest health board, which is, whereas for the non-school base, so for the primary care delivered immunisations, we are for many, many years now amongst the lowest, if not the lowest. And that is a very strong evidence that hesitancy as such is not a key factor in the uptake. It's information, and as Hannah did allude to, what we will be working very closely with primary care, and we have some plans that we're engaging GPs specifically, but also practice nurses, is to enable them to schedule appointments for immunisation and clinics for immunisation in a way that families find it easier, because there are costs of travel. A mum is not going to take time out of work, out of unpaid work, like in Llanelli or anywhere, to get their children to be immunised. They will take time out of work for urgent health care that it needs addressing, but not for healthcare appointments that are proactive. So those are the issues that over the next 3 years in our strategic plan we'll try and build a much, much closer working with primary care and with our local authority, which insofar, from what we've seen, they haven't really had an engagement in immunisation, but they have key enablers in working with our communities.
Okay, thank you very much. Thank you for the paper, thank you for the presentation, for answering the questions. So if I can take you to the recommendations on page 5, we're asked to approve this strategic plan for the for 2024 to 2026. Content to do that? Okay, thank you very much. Thank you both. You're very happy if you want to stay around for the rest of the public meeting, but you can also leave if you want to. Thank you. Right, we're now moving on to, seems to be an ongoing topic, unfortunately, which is the paper 4.10 on Withybush and reinforced concrete. Andrew.
Thank you, Chair. So this is this paper. So that it's fairly self-explanatory, I think. So again, won't go into detail. A couple of things, I suppose. This paper is seeking our approval to award a contract of 1.1 million to cover the latest or the next phase of repair works associated with the programme of work associated with RAC and Withybush Hospital. This particular award would focus on repairing the planks that need repairing in the physiotherapy, the gymnasium therapies area, the north-south corridor and pharmacy. We've used the same call-off agreement that we've used for the other tenders. We sought approval for to support the RAC work, and all of the funding is covered by the £12.8 million that Welsh Government allocated to us last year once we had identified the issues and understood the work that needed to be done to take them.
Okay, thank you. Any questions for Andrew? This paper? No? Okay. Can I just make a plea, Andrew? When we are having to close areas down, and I'm just thinking about the reception desk in Withybush, can you please make sure the teams do put up appropriate signage and professional signage? I was a bit dismayed to see a piece of paper with some sellotape stuck on the window with an arrow pointing to reception and another one saying don't leave post here. So yeah, if you could just ask them to think about that when they're closing an area off, please. Thank you. Sorry, it's my pet hate out of the way. Okay, thank you. If there's no more questions, we're asked to approve the contract as detailed in the paper. Content to do that? Thank you. Thank you, Andrew. So we're now moving on to the Nurse Staffing Act report, the annual report. Sharon.
Thank you, Chair. Can you believe it is the sixth nurse staffing level assurance report that the board has received since the Act came into effect? So many of you will be familiar with the template. It's an All Wales template. It does get reviewed periodically, but to ensure that it's still fit for purpose. The 23-24 annual assurance report sets out the extent to which the nurse staffing levels have been maintained, and that data is presented on pages 12 and 13 of the report. Although the data shows variation in the rosters being met or not met and whether this was appropriate or not, the incidents and complaints data shows that there were no incidents or complaints where the nurse staffing levels not being maintained were deemed to have been a contributory factor. Within the report, since the last report, we've rolled out the Safe Care module of Allocate to all our 25B areas, which has increased the number of users. So all registered nurses now access the system, not just sisters and charge nurses. And as a consequence, they can enter acuity and extent to which data as well. So it was recognised that by increasing the number of users, it could have an impact on the quality of the data. And this is something that we are constantly addressing through training and education. And also to note that slightly inexperienced staff are likely to make different professional judgment about what nursing staffing is appropriate or not appropriate compared to more experienced staff. So that's something that we're cognizant of. So I won't go any further and be happy to take any questions.
Thank you, Sharon. And I should just recognise the huge amount of work that goes into the production of this report. So any questions? Can I ask something, Sharon? I don't think I've ever seen anything come back from Welsh Government to, certainly not to chairs, and it's actually not one of Chair's objectives, and to see any report back from our submission of this annual report. We get feedback from the annual plan, etc., but this is a statutory requirement and we don't get any feedback. Does that come through the nursing directors
Probably
group?
not formally as you describe.
Okay.
So with this report, the annual assurance report, we are not required to formally submit it to Welsh Government.
Okay.
We are required to submit it to board. But I know that the policy office in Welsh Government does read them all regularly. So this report provides assurance to our board, but we also use them then to form the basis of the 3-year report, which we do
does go,
formally submit to Welsh Government. And you're correct, we don't get formal feedback from Welsh on that report, but again, I know the policy officer does pull a summary document together, and he presents that to the Executive Director of Nursing Peer Group then, just pulling the headlines out, which I'm happy to bring back if that would be of interest. So the 3-year report, the caveated 3-year report went to QSEC last meeting, and then the final 3-year report will come to board in September before we are required to submit it to Welsh Government in October.
Great, thank you for clarifying that, that's helpful. So no more questions, so we're asked to receive this report. Happy to do that, thank you, thank you, Sharon. And now moving on to the reports from the other committees. So I've got the first one is Strategic Resources Committee, that Winston.
Sustainable Resources. Thank you, Chair. So we're meeting on the 30th of April, and just want to bring out a couple of things. I won't go through all of the reports. The alerts issue for the board is that we've got cessation of the provision of non-drug allergy service on the 1st of November, and since then we've had to find an alternative arrangement just to let the board know that referring clinicians are able to utilise prior approval routes for the majority of the only 35 allergy referrals. I guess that's a risk to the organisation, but given that there are 35, it's probably manageable. It's not on the risk register, as far as I'm aware, but we'll continue to monitor that. In relation to the meeting itself, just to advise the board on the finance report, we looked at month 12, and we've already covered that earlier in this meeting anyway. We're looking to do further deep dives into medical outcome and other workforce issues, which shouldn't come as a surprise to the board. We did also deep dive into the savings plan at that stage. We know that we've already moved on from that, but at that point we were highlighting the fact that we hadn't identified all of our savings plan for the year, and that there would be a risk, which we've already talked about. In terms of assurance, we're assured about the month 12 out-term position, where we actually met what we said we would do. We also received, which is in this report, great assurance, strong assurance from Medicines Management Deep Dive, where Professor Brown did do a presentation to us, and I think it's also an area of learning because he really demonstrated how well he was working with his clinical colleagues across the health board in relation to bringing the sort of financial issues in relation to drugs, but also the clinical outcomes issues as well. And I think I'll leave it there for any questions.
Thank you very much. Any questions for Winston on this paper? No? Okay, thank you very much.
And there is another report, there's a supplementary to it,
yes, the
which is in relation
report.
to procurement.
Yes.
So we also did get a procurement update.
Yes.
I think the impact of the new procurement manager is being felt. She's doing a lot of great work. We heard earlier that we're updating our GCAP framework, for example. In relation to this, what we're asking the board to do is to approve to commence the tender of the provision of dental services, to ratify the award of all Wales fuel cards, and also to ratify the award of all Wales gluten-free subsidy cards scheme as well. But also, should add at the meeting was that we're really pleased with the range of work that she's started on the health board, and I think some of the areas that she's looking at will really help us with the delivery of our non-pay savings in particular as part of this year's plan.
That's great, thank you, Winston. So we're content to approve those. Thank you very much, thank you. So I've now got the Strategic Development Operational Delivery Committee. Maynard?
Thank you, Chair. May I start by just saying, as other colleagues have, it's been an absolute pleasure working with you for the past 4.5 years. And thank you for everything you've taught me as an IM and all the work that you've put into keeping this health board going. Going to the report, there were a couple of things on the alert side of things, one of which shouldn't have been there, which is the annual report, because it's coming to the July meeting. But the second thing is the maturity matrix on planning was revised and actually has scored slightly lower than we did when we first did the assessment, and we were putting a targeted intervention for finance and planning. So that's attached to the report, and for information, and if anybody wants to ask any questions, I'm sure Sean will be able to answer the questions. In terms of other areas, there are a few areas where we have concerns, but we are looking at them in the committee at the moment. You will see them listed in the paper, and quite a few areas where assurance was received. In terms of the risks, we actually reviewed two corporate risks, but noted that risk 1657, risk to ministerial priorities, was for 23-24, and that was being revised now to reflect work this coming year. So I think we need to actually approve the maturity matrix and action plan. So I'm happy to leave it there and take questions. I know everybody's had a chance to have a look at it.
Thank you, Maynard. Any questions at all on the paper or on maturity matrix? Okay, are we happy to approve the maturity matrix? Yes, thank you very much. Right, so we now move on to the People, OD and Culture Committee. Chantal.
Your Chair. So we met on the 15th of April, and you will see from the report itself, it's self-explanatory. There were no items to alert members of the board on this occasion, and neither were there any items to advise members on the board of this occasion. But what we can do is to give an assurance of the work that is being taken forward, in particular in relation to workforce efficiency, agency costings, because we've already had a report early on to see the trajectory that the organisation is undertaking in order to kind of have a stable workforce and less reliance on agency staff as well. So, and we also saw the closure report where we can see that many of the planning objectives have been met. Some are on track and some are ongoing. One thing that I would say about the committee is that we are going through a period of transition because we are wanting to focus on outcomes and impact of the actions that are being taken by the internal team. So I think as with all committees, we're in a process of re-looking at and re-evaluating what we're doing. But I have to commend the internal team for all of the work that they are doing, despite the challenges that the organisation face.
Thank you very much.
Again, thank you, Judith. Very sorry to see you go, but I'm sure we'll continue to meet.
I'm sure we will.
In particular in terms of health education improvements.
Yes. Thank you, Chantal. Any questions for Chantal? No? Thank you very much. So we now got the Health and Safety Committee.
I'm going to make you upset again now. I'd like to thank you very much for being previous chair and for setting up this committee and doing an outstanding job of that while you were vice chair. And thank you for letting me take over when you went to your interim position. Okay, our last meeting was held on the 7th of May. There is nothing to alert at the present time, but the Health and Safety wish to advise members of the board about the reports being requested for the meeting due to be held in July on the safety concerns raised by facilities agreement about one of the cleaning project's defects. The committee remains concerned regarding the information, follow-up and actions containing within the fire risk element, which we've had in a previous report, and the electrical compliance for low wattage items across the estate remains an ongoing concern. Quite a bit has been achieved, but we do want more feedback in November. Assurance could not be provided in relation to the Health Board's preparedness for the implementation of Martin's Law or the Terrorist Protection of Premises Bill. As indicated, has been received to the NHS hospitals and premises used for the provision of healthcare will be qualifying to act actively for this bill to be applied, and report on the details and impact on the organisation and timelines will be provided at the next meeting. The health and safety governance structure requires strengthening, and work is going to be ongoing to achieve that. The Health and Safety Committee wish to assure members of the board that suitable steps on the management of cable management risk associated with medical devices on beds has been taken on the Health Board site, including electrical safety awareness training and the continuing electrical safety audits. Verbal assurance was provided that the inspections undertaken by the Health and Safety Executive regarding the RAC and asbestos has been positive, and a full report will be shared in the next committee. And the Welsh Health Technical Memorandum compliance continues to require further improvement, with it recognised a vast amount of work is underway. And the board recommendation, the board is asked to note the report and approval of the Health and Safety Committee annual report.
Is the annual report going to...
Yeah, they're all going to the year-end
year-end
July
in
meeting,
July.
Chair.
Okay, so it'll come back the next
back
meeting.
then,
Okay, thank you very much, Anne.
Yeah.
Thank you. And thank you for taking it over and sharing it so well, despite
Thank
your
you.
reservations. Any questions? James, fine.
Thank you, Chair. Quiet from me today. Just to provide some assurance to committee, I'm cognizant that the last board received concerns that we still didn't have our assurance routes as tight as they could be. And I'm most cognizant that ongoing is not acceptable to the board, and I discussed this with the chair of committee earlier. And I can confirm that the 5th of June is the date of which we're going to meet as a executive team, myself, Sharon as the current chair of Health and Safety Committee, and our Director of Corporate Governance, to work through what that assurance plan needs to look like. So that's the 5th of June, just so we've got a definitive date. Thank you.
Yes, I do hope you keep up with the dislike of the word ongoing. Thank you very much. Thank you. Any questions? No. Good, thank you. So we've now got the various committee update reports. Joe?
Yes, thank you, Chair. So the paper details update from the Mental Health Legislation Assurance Committee, In-Committee Board, Health Professionals Forum, Staff Partnership Forums and the Stakeholder Reference Group. As members will see, there are no matters that are required to raise to board's attention. However, there are some areas from each of those where concerns were raised. So just to call them out, the In-Committee Board was in relation to the annual plan, the Health Professionals Forum concerned, which we've discussed the primary care strategy this morning, about separating that out and the perception that acute services could be more important. The Staff Partnership Forum, about ensuring staff representatives are involved in service change each time and not at the time. And the Stakeholder Reference Group was about more engagement in general, Chair. So there weren't any actions to take, but areas from those forums and committees that wanted to be raised to the attention of the board.
Thank you very much. Any questions or at all? No? Thank you. So we're asked to endorse these updates and receive the reports of the In-Committee Board and the advisory groups. Happy to do that. Thank you. And then I've got the working partnership section. We have the joint committees and collaboratives. I think, Phil, that's you.
Yeah, so this paper gives an update on the newly formed Joint Commissioning Committee, the NHS Wales Shared Services Partnership and the Mid Wales Joint Committee. the updates are in the paper. The only thing to advise is that there has been another joint commissioning committee meeting since the production of these papers. So to just give a little bit of detail from that meeting, we received a further update on the EMERTS work, which has, of course, significant public interest, particularly for North Ceredigion. And board will remember that when we discussed this at the last board, there was concern about recommendation 4 and the development of a land-based service. So we did receive further details on that and confirmation about the development of that work over the summer and for it to be ready in early autumn to be considered at our board and in the joint committee. The Joint Commissioning Committee. The other matter of note to highlight to board is that there's a proposal that the Joint Commissioning Committee establish a maternity and neonatal programme looking at maternity and neonatal services across the south of Wales. So that'll be important as that work develops. I feel it'll be important that we engage with that, and the Director of Planning and I have had some discussions already as to how we might link that in through our clinical services plan work.
Okay, thank you. Any questions for Phil on the Joint Commission Committee Shared Service Partnership or the Mid Wales Joint Committee for Health and Care? Okay, so you're happy to receive those? Thank you.
Yep.
So we now have the strategic partnership update. Jill, are you taking that?
Just very, very briefly, Chair, thank you. The details in the paper, but I just wanted to point out that the Regional Integrated Fund, there was an expectation this year that there would be a tapering element applied. As you know, both health boards and local authorities have a significant number of schemes funded through that fund. However, there has been agreement with Welsh Government that the tapering element is removed, certainly at this point, which is welcomed. The overall resource did decrease, and we've had to work around the plans that are funded through this, but at this point that has been removed. And then the final point that I want to raise, and I'm sure that the Regional Partnership Board would expect this, that again we thank you, Judith, for your role as Chair of the Regional Partnership Board for a number of years, and we note that Hazel Lloyd-Lubran will be taking over the Chair going forward. So thank you.
Thank you, Jill. And Rodri is our independent member representative on the RPB, which I'm sure you're enjoying. You're very welcome. Right, any questions for Jill or Ardian? No. Okay, thank you very much. Recommendation again is to take assurance about the working in partnership and note the actions to do that. The next items are for information. Just lost my agenda, but I've got it, so it's all right. And that's the Twice report. Donna hasn't been able to stay, but it was there for information. But I think if there's anything of particular note, if you can forward those through and we can pass to Joe, we can pass those on to Donna. But I would like to record our thanks to Clyde for their production of the report and the work they've done since being in existence. Joe?
Yeah, I was just going to say, Donna's plan is to bring a report through each public board meeting now.
Right.
And Sharon and I have had the conversation about this really needs to sit in the listening and learning from events subcommittee, because there is some really rich information there that we need to use and learn from, Chair. So I think Sharon's going to pick that up through the quality and safety
good.
structure.
Yeah, thank you very much. So the final item then is the annual work plan, which, as you know, is adapted as we move forward. The date and time of next meeting, there's an extraordinary meeting on the 11th of July, which will be the annual accounts board meeting, and then the next main board meeting will be Thursday, the 25th of July. So thank you, everybody. I'm now going to move to exclude the public from the meeting and to move into the in-committee part of the agenda. Thank you, everyone.